Okay, good morning everybody. Welcome to our very first Caring Together Patient Care Experience and Quality Improvement event. I would like to now welcome our Chief Executive, Michelle Moran, to come and talk to you all and welcome you to the event.
Thanks, Mandy. I've not done anything yet. Welcome. So should I do the housekeeping bits, Mandy? Yeah?
Yes, please.
So, good morning, welcome everybody. It's great to see everybody. As Mandy said, I'm Michelle Moran, I'm the Chief Exec of Humber Teaching NHS Foundation Trust. So, welcome to Caring Together event. It's fantastic and I'll come on to a little bit about that. But just a few things. This event obviously has started now and run all the way through the day till about 4 o'clock. Hopefully you've got the papers and things on your tables. The toilets, there's some accessible at the back. And there's some just at the front as you go through where we came in. If you just keep going past the reception opposite the bar on the right hand side, this is where I sometimes feel like an air stewardess where I do things. So please, refreshments will be served out where we've come in, and please do take, I'm sure you will, do take a bit of time just to have a look at the market stalls. They are some really fantastic examples of the work that we're doing together. And there's a few freebies as well, I think bags and pens and various other things, but to entice you to have a look. So please spend the time to do that. And lunch will also be served out there as well. I think lunch is about 12:20, 12:30. If there is a fire alarm, it is not a test, and the fire assembly point is just outside the front. So we in an orderly queue, go out the front, follow the signs for the front door, and it's just out the side of the front door of reception area. If anybody wants any help or support throughout the day with anything, please do contact anybody that's got a purple top on. They will be glad to give you some support and help. What a colleague of mine used to say is, please, if you've got mobile phones, switch them off, because if they ring, I think you should give £1 to our Health Stars charity. And Anita's here. And a colleague of mine said that, and that should be quite a bit of money on his travels around conferences. So, but please, I know people have to be in contact with people, but just for the the social event that it is, and for the respect of your friends and colleagues and people that you sat with, pop them onto silent or vibrate. If not, we may come to you for £1. It's a thought, isn't it, Anita? Anyway, moving on. So anything else, do ask us. And as I say, there will be social media. We've got a hashtag. Hashtag at the bottom. Hashtag Caring Together Event 2025. Please use that on X, we're formerly known as Twitter. And I believe they're talking this morning if that's still up to date, because apparently people can change their algorithms on Instagram. But we are using Twitter today, so please have a look at that. There will be some photographs as well, so if you don't want your photograph to be taken, please speak to James over there and we will help and facilitate that. Okay, so that's the housekeeping done. So why are we here? Well, this is our first joint parent and carer event with our quality improvement team, and it's great to see that coming together, because in the organisation we really want to operate a quality improvement approach. Because everything that we do is about patients, carers and the communities that we serve within our organisation. And we can only do that together. But a real good way of doing that is looking at continuous quality improvement and continually striving to get that best possible care. And sometimes we don't, but hopefully we're getting better at that. Today's event is hybrid, and I think it just shows the amount of eagerness there was and an interest in the conference. So we are live, we are streaming it to about 50-60 people, and obviously we've got the people in the audience today, and I think that's really important because it shows the diversity of the event and what we're trying to do and the geographical areas that we're trying to cover. So it is about caring together, and I emphasise the word together, because I'm great. And when Mandy and I started to look at patient service involvement all those years ago, we said that we couldn't do it ourselves. We had to do it in collaboration with the clinical leaders, the clinicians, voluntary sector, the whole array of support networks that we had, but most importantly with the patients and carers themselves. And I think today hopefully will prove just how much of that we have done and we will continue to do. And it is about continuous improvement and continuous learning. The other thing I think that we're getting better at, and I think hopefully we'll see that today and demonstrate it, is actively listening. Because a lot of the time organisations can listen, but do they really listen? And we really want to listen to what you're telling us and be able to act on that. We can't always, and sometimes it's a bit slower than you would expect, but hopefully we will explain why throughout that process, because it's that constant feedback process. But it's about us working together and you helping us. So I would like today to be interactive. So please do ask questions. And sometimes it's a bit uncomfortable asking questions in an audience like this. So speak to people either on the periphery or during the event. And let's get some proper, some real great feedback from today, not just about the venue, what the market's also like, but if there's anything that you can help contribute to or that you're interested in or any experiences that you've had. And I know there's a wealth of people in the audience which we need to learn from, because we cannot do it without you. We do co-production, but it's about what do we mean about co-production. And a great philosophist once said that what you do makes a difference, but you have to decide what kind of difference you make. And I think that's really pertinent. So have a think about that, but enjoy the day. We've got some fantastic speakers. And I'm really sorry that I can't be here all day, unfortunately, but I will be dialing in online. So I'll be one of those doing it hybrid. So I'm here for a part of it and I'm hybrid on the others. But from our keynote speaker, which is great that we've got the National Director from NHS England, all the way through to some of our foundation doctors, through our different divisions, the digitalisation of what we're doing and how we can develop that through an innovation hub. So let's keep talking, enjoy the event. You've given your time to this event, so please let's make it worthwhile. But thank you sincerely in advance, and I know they'll get thanked a lot, and they deserve that. To Mandy, to Catherine, to the team, and everybody. And I've got a huge list, and if I mention it, I'll miss somebody off. But everybody you know, from everybody that's done the stalls, everybody that's made this possible, but more importantly for you for attending the conference. So let's have that two-way conversation. And I'll now pass you on to, shall I go on the keynote speaker, or are you going to come back up, Mandy? It's all arranged very well.
Thank you, Michelle. Okay, I'd just like to do a couple of introductions. I'm Mandy Dawley. I'm the Assistant Director of Patient Care Experience and Co-Production, and I have the honour of overseeing the Patient Care Experience agenda. And there's my colleague Kath, who's going to introduce herself.
Hi, I'm Catherine Hunter. I'm the Quality Improvement Manager of the Trust, and we work really closely together.
Okay, thank you, Kath. So you'll notice there's a few purple polo shirts dotted around the room. If any of you've got any questions, any queries, anything that you want to know a little bit more about today, please approach somebody in a purple polo shirt and they'll be able to direct you for support or hopefully answer your questions. And also, Michelle's already alluded to photography. If you do not want your picture taken or you don't want to be included in any of the media, we are giving out purple dots on the reception desk. So again, purple polo shirt if you don't want to be included, and we'll give you a purple dot to stick on your item of clothing so that you're omitted from the photography. So I'm now going to introduce our next speaker. It gives me pleasure to welcome Marilyn Foster, who's one of our service user carer governors in the organisation and also does a lot of work to support patient and care experience and quality improvement. Over to you, Marilyn.
I just thought that I would try and let you know how I ended up working with patients and carers, being a governor at Humber, and also QI, quality improvement. I am, for my sins, I'm 78 years of age, and so I was born before the NHS came to fruition by about 3 years, I think. And at that time, I developed asthma. As a 3-year-old, wasn't very pleasant for my poor mum. But because we had then the NHS, instead of having to pay for it, because my mum was a nurse, my dad was an engineer, they didn't have loads of money to pay out for things, and I was ill a lot of the time. So I actually was privileged enough, if you can say that, to be part of the NHS start. And I think over the years, my brother used to say to me, Marilyn, you're a creaking gate with capital letters. So by that, he meant that there was always something going wrong, and I have to admit it's true. But look, I'm here, you know, and I'm, even though I have got a bit of a cough at the moment, I'm healthy. So that's down to the NHS, because everything that I've had done has been by the NHS. So that's the sort of start of it, really. And then I went into nursing. Unfortunately, I was very ill and I had to stop nursing because I just couldn't cope with nights and everything else. So that was the end of that. I then went into management development. And so I was constantly around that word development, which was sort of QI, I suppose, in those days. It was a long time ago. Eventually, because I was having children and I had to travel the country to do that job, I decided that I better retrain. So I retrained as a counsellor. And I ended up in the NHS from, I think it was my late 30s onwards. And because of that, I was at the, I suppose, I was at the early end, and I saw things that could have been better, went, you know, did go wrong and so on. So I was into quality improvement from very early on in my NHS life. I retired when I was 60, and I don't really think I did retire. I didn't retire. I worked as hard. I've worked as hard since when I was actually paid for it. But because I'm so passionate about patients and carers, and because I'm so passionate about QI, I've carried on doing lots of things. If I say to you that right at the start of my retirement, I was asked to be a part of a research project, in fact a co-applicant of a research project, which was about personalised care planning. And this was, I used to live in West Yorkshire. In fact, I lived in Howth, which is on the edge of Bradford. So a lot of the work that I did was with the research people in Bradford, which was quite a lot of research goes on there, and in Leeds, both. And so I was asked if I would be part of that. And also at the same time, part of a frailty project. So everybody was realising that some older people coped better than others, and they wanted to know why that was, even though they had illnesses, there's some people. So we did a lot of research into frailty. I ended up as well being chair, because I was chair of a PPG over there. I ended up being chair of the patient network for the whole of Bradford and District, which meant the PPG chairs and some of their members came. We used to have sort of conferences about once every 3 months. So that was a really informative time for me, meeting all those people and getting people's ideas about, well, what they thought about this and what they thought about that, and actually handing it on. At the same time, I was chair of Relate Bradford, so my mental health training came into play there. And the other thing that I actually started was a charity called Positive Minds, which was about older people and how they coped with their retirement, and was there anything that we could do. This was all about working with charities to see what we could do to help people to become more resilient, really, a lot of the time. And from that, I ended up actually getting £700,000 from the lottery to open a charity called Worth Connecting. And the reason that happened was because when I was doing all my travelling around, I recognised that we all were going to have to be digitally sound, or else we weren't going to be involved in anything. I'm not saying everybody has to be that, but as many people as possible needed to be. So we got, as I say, £700,000, and we started this organisation where people who were computer literate taught the people who weren't. So we'd go round to different organisations, and it's still going to this day. I mean, obviously I've left it behind now, but it's still going to this day. And that was something that was really sort of quite before its time. So again, this was all about improving quality. I then got involved with the National Pathology Imaging Group, which was about 3 or 4 years ago. And that was all about, you've all heard about the AI and cancer, how they've developed that so that they are able to diagnose much earlier because of AI. I'm not saying that pathologists are not involved, because they are, but at least they are using AI in a really positive way. So I was part of that. I was part of the oversight group of that, because obviously there's a lot of concerns around AI. So as a patient public involvement person, I got involved with that. So again, we're talking about quality improvement, helping the NHS to cope with all that it has to cope with. I also been a part of the Health Foundation's Q organisation for quite a while, and I have been an assessor for quality improvement projects for the NHS. So they're asked, NHS, or all the organisations in the NHS, are asked to actually put in projects that are about quality improvement. And I was one of the assessors that were looked at. I think we had 180 odd this last year. But they are sort of looked at before we get hold of them. But we then got about, I think it was about 15 we needed to look through and say whether we thought they should go ahead or not. So that's another way that I've been involved with QI. I'm now the patient carer governor here, which I'm very proud to say I am. And I do get involved with lots of things with Humber as well. I mean, I'm involved with the Innovation Hub, which obviously again is about quality improvement. I'm also involved with the ICB and its good experience sort of oversight group. So there are lots of things that I do as a governor. Excuse me. Yeah. Which are all around patient carers. So I think, as you can see, my experience in the NHS, I feel like I've put to good use over the years. And I'm very proud to be a part of all this, because it feels like we are at last listening and hearing, not just listening, but hearing, which is something I had to do as a counsellor, make sure that I heard. I could, you register words, but you actually hear what people are saying. And I think that we are doing that here, and I know we're going to carry on doing that. So thank you for listening. I hope I haven't bored you. And I'll see you all during the day. Thank you.
Thank you ever so much, Marilyn. Thank you. So next I'm going to introduce our keynote speaker, Dr. Amar Shah. He is the National Clinical Director for NHS England. Unfortunately, he's unable to join us today in person, but he has produced a film for us to welcome you all to the event. So over to Dr. Amar Shah.
Hello, and thank you very much for inviting me to your event together, Caring Together, Celebrating Continuous Improvement. I'm really sorry I can't be with you in person today. My name's Amar. I'm a clinician, a doctor by background. I work as a consultant forensic psychiatrist For the last 13 years or so, I've been working in East London Foundation Trust, now in the role of Chief Quality Officer for about the last 7 or 8 years now, leading the application of quality improvement and building that into a more holistic approach to quality and performance across this organisation for the last decade or more. And for the last year or so now, been in this new role of National Clinical Director for Improvement at NHS England, trying to support the health and care system across England to adopt improvement in a more rigorous way to achieve results for the communities and the people that we serve. I'm absolutely delighted that you're holding this event today, and that you have a framing and a focus around co-production of improvements involving the people who use our services, the people who care for them, alongside our staff in making things better. I really want to applaud your efforts over the last year or so. From the work that Catherine has shared with me already, it's clear that you're well on your way with improvement, and it's making a difference to staff in your clinical teams and the people in your local communities. I just wanted to offer a couple of thoughts which you might want to think about as you work together on topics during the day. The first is just to think about how you can really harness the opportunity of quality improvement to change culture and to change outcomes. We really want to try to support people to think about quality improvement as much more than just a method. It's much more than just projects. When organizations and systems really embrace the opportunity of quality improvement, they see it as a way of being, a way of leading, a way of living, and a way that the organization functions. And to do that, you have to do much more than just run a set of projects. And that's why we co-produced and launched the NHS Impact Framework, which is now almost 2 years ago. And the Impact Framework talks about much more than just quality improvement as a method to solve complex problems. It really thinks about how organizations need to create clear purpose and vision, how we need to really focus on our people, thinking about how we create the conditions within which our people can thrive, thinking about recruitment, leadership, behaviors. We need to build capability and capacity for improvement. We need to also think about how improvement sits within a broader management system. And I'll pick up on some of those themes today. So one thing I'd really encourage you to think about is how your quality improvement work fits in your broader plan for the organization, in the way that you think about your mission and purpose, and really aligning people towards a clear goal that you set as an organization. Thinking about how improvement can integrate and sit alongside other approaches to quality, like assurance, like daily management, operational daily management, as part of an integrated management system, because they ought to be aligned and working together in pursuit of best possible care. You ought to also be thinking about how improvement feeds into the way you think about people and culture, how you recruit people, how you develop people, how you create cultures and climates within teams that enable people to do the very best. And then within that, thinking about how you use quality improvement itself. As I've had the opportunity over the last year to visit and talk to organisations across the country, there is, as you'd expect, quite a lot of variation in how places undergo and adopt improvement. Places that really seem to have brought it into the organisation's way of being, and people feel excited and enthused by it, they are attracted by it, they use it to make things better and to sustain improvements. Those places really apply the scientific rigour of quality improvement, seeing it as much more than just a project run by a few interested individuals. So as you progress into the next year or two of your work, I'd really encourage you to think about how you can encourage people and help people to learn and apply the method with rigour. Part of that is going to be about how we improve together. The best quality improvement work in the world happens when we bring a diverse set of experiences together to truly understand the system and how we can improve it. That, of course, involves multiple professions and different staff groups, but just as importantly, perhaps even more importantly, it involves the people who use our services, people with lived experience, our patients, service users, carers and families. I know from our own experience in East London Foundation Trust, where we began our quality improvement journey in 2014. 5 years into our journey, we stopped and looked backwards at our first 500 pieces of quality improvement work. And what we found was really interesting for us. Although, we always knew that involving our patients and service users was going to be important in quality improvement, I don't think we quite understood how important until we did this retrospective analysis. When we looked at those first 500 projects, what we realized was that those projects that had really, truly co-produced improvement with patients and service users as equal members on the project team, having roles, being part of the project from the very beginning to the very end, those projects were 2.8 times more likely to achieve their aim than all of the other projects. And that's a staggering finding that not only demonstrates how quality improvement can make a difference to people's lives when we involve them in the effort of improving a service. It gives people confidence, it gives people skills that maybe helps them in their own recovery. But it goes much further than that. It also helps us improve in a much more effective way. So we have been really clear in ELFT about trying to understand and improve the way that we involve people with lived experience. In fact, it is a quality improvement project in itself because it's a complex problem. We don't know all the answers about how to do that. And we need to test and learn involving a range of experiences in that. So, we have we created very clear definitions. We used the framing of big I, for big involvement, which is full co-production, and little I, which is occasional involvement, maybe focus groups, surveys, consulting occasionally. We measure every single project to see whether it has big I or little I, and we look at how we can improve the percentage of big I projects over time. And we treat it really seriously in that formal approach of quality improvement, measuring and testing changes to get better and better and better at co-production, because we know how effective that can be in enabling the improvements that we all want to see to care and outcomes. So I'm really looking forward to hearing the learning from your day. I hope it's an enjoyable day. Don't underestimate the power of events like this, which bring people together to build relationships, to learn from each other and to celebrate. Perhaps now more than ever, these sorts of events are even more important for us. And I hope that the work you're doing brings you joy in your work and gives you hope and optimism for the future of the care and the services that you're providing or receiving in your part of the world. So thanks again for inviting me to say a few words, and I hope the rest of the day is a really successful one for you. Thank you.
So, as Amar said, he really wanted to be part of today. So, Mandy and I were delighted with what he had to say. So, just really taking on board what he said for the rest of the day as you're listening, we just ask, can you think of something small that you can do today that will improve your tomorrow? Just to start thinking differently, what could we do today that will improve our tomorrow? We did debate post-it notes, but it's a personal thing. But if you're happy to share it, please use that hashtag Caring Together Event 2025 and we'll pick it up from there. But looking forward to hearing more. Thank you.
Okay, so we're going to spend the next section of the agenda talking about all things patient and carer experience and quality improvement. We're going to share with you our journey, where we want to go next with you all, and basically thank you all, because without you, everyone in the room, we wouldn't be where we are today. So just to give you an insight into patient care experience and quality improvement and where it sits in the Trust. So Dr. Kwame Fofi, the Executive Medical Director, has both patient care experience and continuous quality improvement in his portfolio that Kath and I oversee. And then, of course, the rest of the organisation underpins the both agendas. So we have engagement leads in all of our divisions across the organisation as well, and you will be able to visit their presentation stands in the adjacent room over the breaks and over lunchtime. And if you've got any questions about any of our divisions, so children's and learning disabilities, forensic services, mental health services, community services, primary care and addiction services. I'm now going to introduce you to our 5-year forward plan for patient and carer experience. Over the past few years of me in my role, I have overseen 2 strategic plans for the Trust. We had our patient and care experience strategy, which was our first strategy 5 years ago. And then 23 to 28, we co-produced with you all our next 5-year forward plan, which shares with you how we actively listen to, hear, engage and involve you in trust activities. So we're going to share with you now a short film which gives you the highlights of our 5-year forward plan. And if you go on our website, you will see the 5-year forward plan in detail.
We are delighted to introduce our new patient and carer experience forward plan. Our community is at the very centre of everything that we do. There is no better and more important way of improving services than by listening to what individuals think, feel and experience throughout their care journey and beyond. This forward plan will set out how we will listen, support and work together with our patients, service users and carers.
As a service user, carer, governor and a patient, I am passionate about improving services within the Humber Teaching NHS Foundation Trust. We are on a journey which changes and improves each year, but the main focus is always the care of the patients, service users, carers, staff and the community.
Over the next 5 years, we will achieve 3 outcomes.
Our care is informed by lived experience, involvement and engagement to ensure our diverse communities feel heard, valued and understood.
Our strong partnerships enable us to empower communities, address health inequalities and deliver integrated care that meets local needs.
Our staff are supported to involve our communities in all aspects of our work.
Across the Trust, we will pay people with lived experience to work together as equal partners with our staff to develop and improve services. Patient information will be produced in partnership with our patients, service users and carers across all services. We would work with our partners across Yorkshire and Humber on joint projects.
Children and young people will be able to access the Youth Recovery and Wellbeing College, Humber NHS Cadet Programme and work experience in our Trust.
Patients with learning disabilities and our families will help to train staff.
We will improve engagement with carers and family members throughout our forensic services by hosting open events and promoting family engagement training for our staff.
Patients and carer experience champions and volunteers will support our community hospitals, GP practices and addiction services to collect feedback to enhance patient and carer experience.
Our Humber Recovery and Wellbeing College will empower local communities, including people experiencing health inequalities, to support their own mental health and well-being.
I get the last word, but it's your voices which count. Over the past 5 years, your involvement and engagement in trust activities has helped us to significantly improve the care we provide to our communities. Moving forward, our patient and care experience 5-year plan will guide us to continue on this journey. Thanks to everyone who has contributed.
So just a little bit of reflection. Our 5-year forward plan has 3 outcomes, and these 3 outcomes, our care, our partnerships and our workforce and organisation are aligned to our 6 strategic goals. So if you want to reflect on this a little further, please visit the website, patient and carer experience pages, and you will see the full detailed plan with all the information. Now, we have 3 time trajectories that we're working towards. Time trajectory number 1 is years 1 and 2, which completes on the 31st of March this year. We have a series of action plans and milestones that share with you how we have achieved what we're saying we want to set out to achieve in the plan. So we're nearly at the end of year 2. We'll be action planning over the next few weeks for years 3 and 4. So it just shares with you that this isn't a plan that sits on a shelf. We are continuously working with the plan, and it continues to evolve as well as new projects and initiatives come to light.
So in terms of continuous improvement, there are a number of drivers, a number of pieces of work that provide that direction. There is a quality improvement strategy 2021-2026 that has 12 priorities. It was co-produced, co-written to give direction of where we should go in those early days of the strategy. The impact, which Amar has touched on, has 5 different components to it, and the Trust has developed, done an assessment and then developed an action plan to try and build on where we're already at from an improvement perspective. And then the other area that impacts us is the national, regional projects. There's a few mentioned there, but that will sort of provide that direction to the Trust as well. We use the model for improvement as our methodology, but I've got a much better way of telling you all about it now. We've got a short film, again, that was co-produced with a number of people who are in the room, so thank you for that support.
The Trust takes a systematic approach to building a culture of learning by bringing together staff, service users, carers, and those with lived experience. This collaboration helps everyone share ideas and combine perspectives to solve problems and design effective solutions, big or small. Ideas can come from anyone, anywhere. To guide our efforts, we use the Model for Improvement methodology. It starts with 3 key questions. What are we trying to accomplish? How will we know a change is an improvement? What changes can we make that will result in improvement? We then test ideas using the Plan Do Study Act (PDSA) cycle to refine and implement solutions. The sensory room was dull, had unsuitable furniture, and wasn't being used by staff or service users. We set out to transform it into a space that appeals to the 5 senses, promotes engagement, provides a safe, quiet place to de-stress, supports mental and physical well-being, offers a holistic space to relax. We started by setting clear goals and forming a project team of staff and service users to discuss ideas and predict outcomes. We first addressed the colour of the room, making our first improvement, painting the walls in calming colours and replacing the furniture to make the room more inviting. Next, we added a mural to one wall for a creative, uplifting touch. Finally, we installed mood lighting, allowing users to adjust brightness and colours to suit their needs. These changes made a significant impact. Room use increased from 0 to 10 to 12 times per week, and service users reported feeling calmer and safer, especially during times of crisis. We continue to explore further improvements, documenting our progress to guide future projects. This demonstrates how the model for improvement can create meaningful, lasting change. We hope you enjoyed learning about how the model for improvement works.
Thank you. So that just really gave an overview of the model for improvement. But the third question was all about thinking differently. So just to have a break from Mandy and I talking, we've got a little bit of an exercise. It's one that's included in our training. On the table, you have a rather large rolled up sheet of circles, which looks a little bit like that, but it's a bit bigger. If you nominate an artist, we're not going to score the... We're not going to score the way it's drawn, but nominate an artist and have a go at converting as many of the circles into different things as you can. I'm going to give you 3 minutes. I'm going to time it because that's what we do in the training. You can go for anything. I've given 3 examples there. You could go for a pizza, a clock, an emoji. What I would say though is please don't do a whole sheet of clocks or a whole sheet of emojis. See how you get on. If you've done it before, you have got a slight advantage. Sorry, if you're at home, can you get your sheet ready and you'll have 3 minutes to have a go as well. Thank you. Are we ready? Is everybody ready? Timing starts now. One minute left. And stop. Okay, can everybody stop now, please? Thank you. Okay. Right, you've had the 3 minutes. Hopefully you've got a full sheet of ideas. If you're at home having a go, please can you put something in the chat, how many you've filled, what ideas you've got, and we'll come to the chat in a moment. In the room, Sarah Fee, can you have a mic ready? In the room, how many did you manage to fill? So put your hand up if you want to say how many circles you've filled.
23.
23.
Any higher than 23? 30. 18.
Can anybody beat 30? 34.
Any higher than 34?
36.
Oh, you've got 36.
So,
this level 36.
Lots of thinking outside the box over here. So in terms of your ideas, has anybody got anything that they're really proud of, how they did their circle? Anything come through on the chat? Nothing on the chat.
I've got to share this one. I like this one.
All right, Mandy sharing.
A turtle.
Oh, good. We've got a turtle.
Any fancies on a turtle?
Oh, Mandy, just come back with that one. We've got as well, I know that no one can see it, but we've got several circles joined together. Is it a flower? It's chainmail. So several circles joined together as chainmail. Any other ideas? A rabbit? Traffic lights. Fantastic. So, pair of glasses, brilliant. So thank you everybody for having a go at that. As I say, it's an exercise we do on the training just to think a little bit differently, just to break up the talking. So I'll hand back over to Mandy.
Okay, so I now wanted to touch base on how we enable you to get involved in trust activities, so you can find out what activities and opportunities are available. We have various forums, as you can see on this slide, and as well as forums, there are other ways that you can give feedback. It may be through participation in our surveys, it may be from, we like to call it, you said we did. So you tell us what, it may be something that you want to share with us where we could make an improvement, and then we will follow that through the quality improvement process. For example, we did, and then we'll share back with you. So if you go on our website again, there is a section on the website for all 4 divisions that shares with you a history of you said we did activities that were performed in the organisation. So it's closing that loop and sharing with you what we've done on the back of your feedback. So our patient and care experience forums, because of our large geography, we have 3 different forums, one in Hull and East Riding, one in Scarborough and Rydale, and one in Whitby and District. If you want to join any of the forums, you are most welcome to. And please get in touch with the patient and care experience team, and we will share with you how to join. Also, again, on the website, there's details there. We have our Staff Champions of Patient Experience Forum. This was the very first forum that we created, and that was on the 5th of October 2017 that we first met. There are now 219 Staff Champions of Patient Experience in the Trust, and they are identified through our purple lanyard section of our Trust lanyards. So you'll see there's a Staff Champion of Patient Experience on there. So whether you are a patient carer, service user, or you are a member of staff, it's an identity, and those individuals join the forums, come and listen to best practice, and also support the patient care experience agenda. We've got specific patient service user carer groups that take place across all 4 divisions. For example, we've got the Our Voice group for the Forensic Services division. We've got an adult care production group for our mental health services. We've got our Humber Youth Action group, where 11 to 25-year-olds participate in that group. And we've also got our patient participation groups throughout our primary care GP surgeries. We also have our Veterans Forum. The organisation is accredited as a Veterans Aware Trust. where we support our armed forces community. We do a lot of work with our regional and our national veterans leads. We also do a lot of work with our armed forces community themselves. In the Veterans Forum, we've got staff who are veterans or who are have partners that are in the armed forces. We also have partner organisations that come along and our veterans community, and we get some really good discussions going in our Veterans Forum. It's a real supportive group, and I really do influence and encourage anybody in the room. If you're a member of staff, we're looking for armed forces community navigators, very similar to staff champions of patient experience, but your role would be to attend the Veterans Forum, to support the Veterans Forum, and also to participate in training, which actually, it gives you that, equips you to be able to support and signpost your patients, service users and carers. So please, again, come and find me during the day or drop us an email in the Patient Care Experience mailbox to learn more about that one. And then our Chief Executive, Michelle, chairs our Humber Co-Production Network. And that is a network of our partner organisations that work very closely with the organisation. That's health, social care and education sector. And that's a really good forum for sharing best practice. And that's from both sides. Our organisation shares what the organisation is prioritising, but also we invite our partner organisations to attend and support their agendas as well. This just gives you a flavour of some of the trust activities available for members of the public. If you want to see this in more detail after this conversation at break, we've got lots of these leaflets over on the Patient Care Experience stand number 2, just as you walk through the doors. Just gives you a flavour again of all what we're doing to involve you in our trust. So we've got things from, there's obviously research, I've mentioned the forums. We offer you the opportunity to come and share your story of accessing our services to our trust board. We have our Recovery and Wellbeing College. We've got trust membership. If anybody wants to become a member of our organisation, we have our trust membership stand through the doors. And again, you can join as a member and get to know more what's going on in the organisation. And trust membership can enable you to become a governor should you wish as well. All of the information on here, there are stands through there that share with you in more detail the work that we do. Another passion of the organisation is recruitment and panel volunteers. We really do encourage our services to involve a patient carer or service user on an interview panel, or have a service user, patient carer panel that stands aside of the interview panel and feeds into the main interview panel. So there's 2 different ways of doing it. But again, we really do, from an emotional intelligence perspective, values, we really do encourage patients, carers and service users to support with the recruitment of our future workforce. Here are some of the priorities that the Patient Care Experience agenda are currently focusing in on. I'm not going to read every box, I'm just going to pull a couple out. The first one I want to pull out is our Experts by Experience initiative. So over the last 8 years, we've worked very closely with patients, carers and service users at our forums. More recently, over the last 2 years, we have developed our Experts by Experience initiative, where we have a database of lived experience volunteers who support the organisation, and they get paid for their time and their commitment on projects. So in our divisions, if a piece of work fits the criteria to involve an expert by experience, we invite Experts by Experience to support that work. So it's working in equal partnership with our staff on pieces of work where there is a defined outcome. It may be supporting with the development of training, actually supporting with delivery of training. It may be supporting with a future policy, a future 5-year plan, strategy, etc. But we really, really are passionate about involving you in everything that we're doing, and the Expert by Experience initiative, slightly different to being a volunteer or a patient and carer experience champion, because we reward with payment for that, for those projects and initiatives. And the other one that we're really proud of is our co-production logo stamp. So we have our trust branding, we have our trust logo, we have our values, our caring, learning, growing branding on our documentation, but also on the front sheet of our documentation, if a piece of work has been co-produced, working in equal partnership with our patient service users and carers, and it fits the criteria, there's evidence that it was co-produced, then the logo stamp is awarded for that piece of work. And that piece of work, the logo stamp sits on the front, so straight away we can see, along with the trust logo, that that piece of work has been co-produced. So we really encourage our workforce, our staff, to apply for the co-production logo stamp when they've co-produced a piece of work with our lived experience audience.
So again, for quality improvement, these are just some of the priorities coming up for the foreseeable future. Again, I won't go into everything. The co-production that Mandy's mentioned is really key for quality improvement. Amar talked about it as part of having almost 2 tiers of patient care involvement. And through the co-production logo and an automation of the quality improvement charter that automatically sends an email to Mandy's team saying, are we able to have the co-production logo, we're able then to have those 2 tiers. So we're starting to see the data coming through and showing where we've got patient care involvement throughout the whole of the project. The other one I'll mention is the Innovation Hub. There's a little bit of information on the QI standout in the refreshment room, but also you'll hear a little bit more about that after the break. In terms of how to get in touch with anybody in Mandy's team or the QI, these are our contact details. You'll also find the information on all the leaflets on the 2 stands through there and on the Trust website. So there's lots of ways to get in touch, telephone, email, and the information's already there. Any questions?
No questions? Is there any questions in the live chat? No. Okay. They're 2 or 3 minutes behind. All right, okay. Thank you. Okay, well, no further ado then. We'll complete our presentation and we'll move over to our next presentation. So please can I welcome up to the front Dr. Matala, who is going to talk about quality improvement projects on the Avondale ward.
Thank you. My name is Mohammed. I'm a foundation year 2 doctor, and I worked in the trust between August and December of last year. So I was on Avondale ward, and just a brief background on the ward. It's an acute psychiatry unit which has 14 beds. And in terms of doctors, we've got 1 consultant and 4 junior doctors on the ward. And in terms of our duties and responsibilities, as junior doctors, it's our duty to clerk and when patients come in, so basically take a history, examine them, come up with our diagnosis and initial management plan. We are also responsible for the physical aspect of their well-being, so physical examination, ECGs, bloods, and we take part in CPA meetings, review meetings, discharge meetings, and we are responsible for completing discharge summaries on time as well. And because it's an acute psychiatry unit, we've got a huge, very huge turnover of patients. So work in this ward is quite fluid, and we have to adapt to different circumstances. And I think speakers before me have already touched on why we actually take part in quality improvement projects. And at the heart of it is patient safety, but also to improve the experience of patients and service users, and to improve carer experiences as well. And in terms of how do we come up with ideas for quality improvements, it's mostly through reflections, and these can be either on a personal level or reflections on a collective level, where we speak to each other on the ward and come up with ideas and talk about our day, see what went well, what can be done, what can be improved and whatnot. And in terms of the quality improvement projects that we came up with on the ward, we came up with 2, and one was to streamline jobs and responsibilities on the ward, and this then led to our second quality improvement project, which was to improve discharge summary completion. And when I came onto the ward, what we realized was the system of of the junior doctors completing ward jobs was not very efficient, and what that led to was basically inappropriate tracking of the jobs, where there was a problem in communication, where we wouldn't know what jobs had been done for patients, what still needed to be done. Sometimes there would be repetition of things that had already been done. And we came up with a simple improvement, and that was to come up with a jobs list that would be in a place which is easily accessible. And everyone on the team would then keep on updating that list throughout the day. And in order for us to show an improvement, what we did was, before the intervention was implemented, we asked the doctors to complete a questionnaire which would rate various aspects of the daily jobs, which included confidence, tracking jobs, handover of jobs, repetition, and just an overall rating of how they found working on the ward. And if you see the blue line, that was their rating before the intervention was in place, and the orange line on top is basically their ratings after the intervention was put in place. And it did show an obvious improvement in the overall experience of doctors on the ward. What this then led to was, we realized that despite this intervention in place, we still were not completing discharge summaries on time, and we had a slightly increased use of paper on the ward. And this then led to our next quality improvement projects. Now, discharge summaries, it is our responsibility as junior doctors to complete discharge summaries on time. And for patients, it is, and for GPs as well, it is the only communication that GPs will get from a ward about what has taken place on the ward, what new treatments have been put in place, whether any change has been made to their previous medication. And the standard is to complete all discharge summaries within 48 hours and send them off. And we knew we were not doing too well. So what we did was, we analyzed 11 discharge summaries retrospectively. And we were shockingly, 36% were completed within 24 hours, 0 between 24 and 48 hours, and majority, more than half, were actually completed after 48 hours. And we realized that we really needed to change this. And what we did was, then we came up with a separate piece of paper, which again was in an accessible area, and everybody on the ward would then keep on updating this throughout the day and throughout the week on who was discharged at what time, on what day, whether that discharge summary has been completed or not, and whether there's any communication to GPs or community teams that needed to be put in the discharge summary. And with a simple improvement like a jobs list, or a simple improvement like a piece of paper which was easily accessible and continuously updated, we saw a massive improvement, where more than half of discharge summaries then were completed within 24 hours, 45% within 24 to 48 hours, and we actually met the standard of completing all discharge summaries within 48 hours of a patient getting discharged. And the outcomes of basically our quality improvement projects was increased efficiency of our work, definitely improved patient safety, because we managed to complete all discharge summaries on time, and we had better carer experience on the ward after this as well. And in terms of the future, what we decided, we would still improve these, we would still do more quality improvement projects. One was a green QIP, where, because we would come up with jobs lists on pieces of paper, we thought it could be turned into a green QIP, where instead of using paper, we could have an Excel sheet which could be updated throughout the day. And also, because this was done on the acute psychiatry ward, it created this buzz in the ward, where nurses also noticed that there was a discrepancy and there was problems in communication between doctors and nurses, and they wanted another project where we would improve communication between nurses and doctors on the ward. Anyone have any questions, comments? Yeah.
I really appreciated that summary. I could see how hard you are working. I could see how hard you're working with gathering information about impacts, what's happening, and so on. Right now, you will be more than well aware of the media exposing incidents on the media, television particularly, And I'm wondering whether you and your colleagues have had had any impact on that sensationalism that's going on. You know, I'm talking about very serious incidents now, which you probably you recognise I'm hinting at, without going into detail. So I'm wanting to know whether, in fact, there's been any impact for the media coverage of very serious mental health behaviour, you know, involving the public. Just to take.
Well, I mean, I think that does impact on what quality improvement projects we do take part in, and I think it does give us more. I don't know how best I can put it. Yeah, Dr. Fofi will answer that.
I mean, there's this note about the project which Dr. Mohammed has kindly explained to us, but the doctors, nurses, and professionals in general do take into consideration what is happening in the media. And there is a concept which talked about the secondary victim. So when there's an incident which happens to a patient, every clinician that I've worked with do suffer what we call secondary victim. And all of us beat ourselves in the back when things happen, especially when they hit the media landscape and we get negative press about it. That even multiply the secondary victim that we suffer.
What I'm really getting at here is about the negativity that this stuff coming on the television.
Yeah. Thank you very much. Thank you for bringing it up.
Yeah, I mean, I think that's what Dr. Fuffy was actually saying about the negativity of the secondary victim, and one of the things that we do is obviously learn from the national events as well as local events that happen, but try and support our staff as much as we possibly can do, because it is that negative opinion of the NHS, and I don't just think it's in psychiatry now. I think there's a general negativity from a media point of view, and what we try to do is not operate a blame culture in the organisation. That doesn't mean we're not a learning organisation. It's core to our values, but it's about how can we learn and support people when things don't go as well as we expected them to, because we're all human. I'm a nurse by background, but we're all human and we can all learn from that. But even if it doesn't affect them here, from example in Nottingham, we have to support staff through that process, and hopefully with some of the things that we do, both psychologically, pastoral, but also from a development point of view, that we do that, and we're constantly asking staff and checking in and saying how they're feeling. But it's a really good point, and it is something that we are trying to look at from a national perspective, and obviously today's in the independent report. I'm not going into whether that's a right thing or not, but we need to support staff through that process.
Could I pick up on a point that you raised? You did all this work on Avondale, which was certainly improved the efficiency, it would appear, of processes. You put up a piece at the end which said it resulted in better carer experience. Can you give some examples? Because that's where I think is the important point. What was the better carer experience as a result of that work?
So first of all, I think it's the system that we had was basically just asking each other what's been done, what's not been done, and I think if you don't have a system in place and you don't really know what's going on, it's, you know, you come into work, you don't know what's going to happen, and when you leave work, you don't know whether you've completed everything that you were supposed to complete or not. And with this, a better carer experience was we would be more satisfied with what we had done at the end of the day. Completing discharge summaries on time as well. In terms of a better carer experience, we felt we did what we were supposed to do.
Worker experience, not carer as a lived experience.
Because that, for me, is the important point as well, just as much as anything else.
I mean, I could probably suggest, I would imagine, that it probably did have an improvement on carer experience from a point of view of, you know, if you don't have a thorough discharge summary from somewhere, then in actual fact that can lead to kind of disjointed follow-up care. It can lead to Okay, joy. all I was going to say is that I think it probably would have some beneficial effect for lived experience carers as well, because I think if there's any kind of breakdown in communication, particularly post-discharge, then that can have an implication for, you know, follow-on treatments, for maybe understanding where to go or tap into future supports just to maybe stop a future breakdown, or to prevent readmission. You know, there are lots of reasons why actually having that thorough kind of clear discharge within a decent time frame will actually probably have positive impact for both lived experience carers and patients. But yeah, I think you was talking about care workers, weren't you?
No, I echo that, but the other thing I was going to mention in terms of care experience and patient experience is also good, because I know that having worked in the ward, sometimes if the discharge letters don't go quickly, you have occasions where patients sometimes phone the ward to say, we've been to the GPs, the discharge letter is not there. Or the carers will say, I went back to the GP to pick the medication that you said I should have, and it's not there. And that is why nationally we're keen to hit the benchmark of getting the discharge letters quickly there. So that definitely will have a positive effect on patients and carers as well in the community. Thank you.
Thank you.
Thank you very much. Okay, we've now reached our first refreshment break, so there's drinks served over in the adjacent room. Please have a walk around the stands, talk to our colleagues, and we'll come back here for just after 11 o'clock. Thank you. Hello everybody, welcome back. Hope you've all had a drink, cookie. We're now going to move on to our next part of our morning agenda. So I'd like to now welcome to the front our Mental Health Services Division, who are going to talk to you all about an improved young onset dementia pathway.
My name's Kirsty, and I have a couple of titles. My main title is I'm the clinical lead for the Hull and East Riding Memory Assessment Services. More recently, I have been given the title of the Young Onset Dementia Lead for older people's mental health services. And that really is just about trying to highlight and raise awareness of the fact that there is this growing need for younger onset services for people with dementias and memory problems. So that's really why that's been added to the title, is just to really try to raise that awareness. And also so that as I go through, you'll sort of see that some of the developments we're trying to create are trying to home in on kind of providing champions in all sectors. So my role will be to sort of provide advice, support and coordinate that to make sure that there is tailored support in all the areas. So I've been told this is really straightforward. Good. Okay. So for those of you that have been involved in kind of older people's care, you may well already be aware of this agenda, but this is a very nationally driven agenda for the Living Well with Dementia pathway. And pivotal to that is this Diagnosing Well section, which is where my service fits in. But the diagnosing well section then has implications for supporting well, living well, and dying well. So it really is quite central that we get this right and we do it in a timely manner. And obviously we're very aware of the fact that there are several challenges for that in general. But what we have started to see is that there is a growing number, both nationally, but for us personally, locally, a growing number of individuals under 65 that are being referred through to memory services for potential dementias, for potential neurodegenerative memory issues. But it's quite a unique presentation, and it often isn't quite the same presentation as those individuals that that are over 65. So we wanted to pay it a little bit more attention. We were getting anecdotal feedback from people that were coming through the pathways that it felt a bit disjointed, and also feedback, so people from patients themselves, from their carers, but also from other services trying to use our services, so GPs, etc. So we wanted to look at how to improve things. What we needed to do was acknowledge, I think, the very unique base of what young onset dementia looks like and what the unique set of needs they may have. And obviously, there are often different set of challenges, quite a unique set of challenges, compared to the sort of more common older people's challenges that they may experience when they have dementia. And obviously these can include things like, there might still be young dependents, might be also looking after older dependents, depending on the age of the individual themselves. There's often a number of other comorbid health problems, be it physical health problems or maybe some addiction issues running in parallel. So there's often other things to kind of tease out, as well as other milestones within people's life which can actually mask or hide the fact that maybe people have memory problems. Often people getting misdiagnosed with menopausal issues or depression or things like that. So that all of these things are taken into consideration. And accessing timely diagnosis, obviously we've just said already that that's key in general, but with this particular age group, it's already well established that it takes over twice the time to get a diagnosis than it does for those over 65. So we really knew that this was something that we needed to look at to see how we could improve the flow and make things easier for people to get that diagnosis. When we started to look at that, we started to therefore analyse the data of the people that was coming through to our services. What we started to see was that actually quite a large number of the people that was coming through to us weren't then diagnosed with dementias. So there was a high proportion of individuals that were coming through that actually needed different services. What they actually needed was, support with depression, or they were going through some significant life stressors that needed support with that. So they, and what was happening was that they were having potential concentrational issues which were presenting like they had early signs of dementia. So they'd been referred to our service, been through all the steps in our service to then be told, actually, you now need these other services, which the feedback from patients and their carers was that was an extremely frustrating experience for them. It meant that there was a significant delay in them accessing what they actually needed. On the flip side, what this also meant was the resources that had gone in to supporting that individual to go through that part of the memory journey was then making it less timely for those that probably did need to access the service, because they were then having to wait longer to be seen. So we wanted to look at how we could improve the process of making sure that the right people were the people that came into the service, to try to make sure that they did get access to specialist memory assessments in a timely manner for those people that needed them. So the way we set about trying to do that was improve the triage processes, skill up the kind of multidisciplinary workforce, so right across the board, not just within the memory services, look at alternative services earlier in the process to make sure that they weren't having to sort of wait, and increase the mode of assessment once you actually kind of get through into the services. The post-diagnostic stuff is stuff that we're kind of working on now. So this is the stuff that we're sort of, it's growing at the moment. But obviously, again, it's about upskilling the workforce, both within our own services, but also trying to work with primary care and GPs and people like that. Working very strongly with our kind of partner agencies and the voluntary sector and some of the support agencies around us. And this is the bit that I was just talking about the, you know, I've now sort of took on this role as the lead, and I am now looking at how I create those champions within the different sectors. Okay, so the referral pathway now. So the brain health workers is just up there really briefly, just so that you have an idea of the fact that, you know, we are in that, on that well pathway. Obviously there was prevention up there as well. So the brain health workers really are about that kind of earlier step. They're about working with people to identify in community that there may or may not be issues and try to support them around that. Prior to GP referral, obviously, again, as we've just said, one of the key things that needs to happen is we need to educate, we need to be guiding as to when people might need referral, what might need to be done beforehand. We did tentatively start to do some of that work prior to the GP collective. It's kind of took a little bit of a backseat at the moment, just whilst things are as they are, but it is something that we intend to, you know, rekindle again. The main bulk of the changes occurred around educating and working with the adult mental health teams, because what happens for individuals under 65 is they do initially get assessed and triaged by the adult mental health triage and assessment service. So what we needed to make sure was that they had the right skills, they had the right knowledge to know where, you know, what probably did need to come to the memory assessment service and actually what needed to be directed elsewhere for support first. So we spent quite a lot of time working with them and produced a one-page document to try to guide them, which helped them to quickly look at if there was any specific red flags where they maybe needed to be directed to neurology for more kind of urgent assessment, if there was, what criteria they would need to fit to actually be directed to the memory assessment service, and then what other areas maybe would be more appropriate. And the reason for doing it on a one-page document like that was to try to help with, you know, staff turnaround, things like that, so that, you know, whilst we can go in and do training in team meetings and things, which we've also agreed to do, there needed to be something that could be passed on to staff and that people could also have a quick look at, a quick glance at. We also set up a system where there was access to advice and support from our service if that was required, so that we have that link, and we have regular correspondence between the clinical leads of mental health triage and assessment service and myself in order to make sure that that is working well, looking for good examples of good practice and also looking for examples where maybe that hasn't been quite so good, so that she can work with her team to sort of identify where this has gone well and maybe where it's not gone so well. They then come into the memory assessment service, and what we now do is we now have a small MDT of quite senior clinicians that are experienced in young onset dementia, which is myself, a consultant psychiatrist and a clinical psychologist. And we take the information that has been done at that triage and we look at it and do a further paper triage to determine whether or not that we agree with that kind of synopsis, whether or not they do need to come to us, whether or not we actually think they need to go somewhere else. If we do think they need to come to us, at that point we can make a decision about whether or not we think any additional scanning might be required, whether we think any additional testing might be required, and we can actually make those requests at that point rather than waiting for them to have their assessment and then making, so that kind of speeds things up for them. But equally, for those where we don't think they're appropriate for our service, what we've now set up is that I then take those individuals back into the mental health interface meetings with the adult services to speak to them about where is the best place for this person to be be redirected. And that's really helping as well with that kind of education and training loop, but both ways, because what it also means is we're now becoming more aware as well of what services are there for younger adults, what can we tap into. So it's working really well in both ways. So this, obviously, once they do manage to get into, if they do come to the memory services, then they will be seen by a senior clinician to complete their assessment. And again, this is just to prevent there being too much repetition and them having to have like an assessment and then us saying, actually, this needs someone more. And we kind of learn from that, you know, so we do now know that if they're under 65, we will always appoint them to a more senior experienced clinician. They'll do a comprehensive assessment that looks at everything. As I say, we will look at, we'll ensure that they definitely have structural scanning, so they'll always have that. But we'll also look at whether or not any additional kind of more enhanced scanning needs to be done, whether or not they need any specific tests. They've got access to psychological tests, they've got access to additional psychology testing. Will often involve occupational therapy if necessary. And we also have a regular consultation with neurology, which is set up. And again, that helps us to discuss those more complex cases where there is uncertainty. If an individual does have a dementia, then obviously we meet with those people. And again, the feedback from people with lived experience was that, you know, these were the key things basically that they wanted at that appointment. But what they was loudly and clearly saying was that actually there needs to be an emphasis on hope and empowerment. These individuals often have hopes, aspirations, and things they wanted to achieve both before retirement and after retirement. So there does need to be a focus on, you know, how can these things still, you know, how can we work with these individuals to still try to achieve these things? What agencies are there that can help with these things? They're often much more physically active, might want to continue with sporting activities. How can we link in with health training? Various different ways that we need to kind of just subtly change our diagnostic disclosure to make it more appropriate for that age group. And language was the thing that they said was absolutely pivotal. So it's that, you know, the delivery and the language of how that was given. The post-diagnostic support that's provided, we all the usuals, but what we're trying to do very much is work very closely with our partner agencies. So it's very much about, it's not all in-house, it's not all about us, it's like we'll kind of do that initial post-diagnostic disclosure and give them that support. They do remain with us for a few months to make sure that they can tap into us as required, but it is very much about trying to enable them to access the right agencies and the right support within the community. And we've certainly got, locally, we've got, you know, the Alzheimer's Society, Dementia Forward, they're all kind of doing specific groups, specific targeted activities and things aimed at younger onset dementia. Okay, so the next steps. So a bit like everybody said, really, you know, we're very much about how can we continue to improve. So it's not just a case of, well, we've done this and that went well, so, you know, let's get a little star award for that one. Well done, us. It's very much about how can we keep improving this? What can we do? So we are very much looking at trying to enable this championship role. What we want to do is make sure that there are champions in every community mental health team in older people's settings. So that as and when, if they need advice and support, that's there, and that people know within their own little team who to go to for that information and support. But equally, we want to make sure that they're also available in the adult services so that the younger adults, you know, mental health triage, mental health crisis intervention, that they also have this information available. Very much want to try and look at doing some future work around the hard to reach groups. Because whilst it's acknowledged that young onset dementia in itself is a minority group, what is also known is that people in ethnic minority groups, for example, have a much higher prevalence of developing it, but are also much less likely to access a timely diagnosis and access their. So we want to kind of look into that and see whether or not there's anything we can do locally to improve that for people and to encourage people to come to us and to make sure we've got the right assessment ability and also post-diagnostic supports for them to make that meaningful. Looking at improved use of technology and choice, and again, this has come back about directly from feedback from patients. So some patients have said to us that actually because they might still be working, or they might have physical health issues, or that actually from their perspective, some of them would like to have been able to not have had to come into a clinic, but done something remotely. So maybe had their first initial session via, some kind of video conference or something like that. And so based upon that, we are now going through everybody that's on our current waitlist that's under 65. We're going through them to ask them their views about this, to try to gather, whether or not this is something that needs to be offered. So far, the data that's coming through is that for some people, it's absolutely what they would like. For other people, they'd still like to be face-to-face. So essentially, what needs to happen is they need to be offered the choice. So that's something that we're kind of going to be moving forward within the next few months, is that we're going to start offering that as an option. And then, yes, open access to support throughout the full wellbeing pathway. So that kind of just ties in more generally with the older people's mental health 5-year strategy, because we are moving over the next, we've got about another 3 years to go, but over the next few years, we are trying to move more towards there being a seamless kind of ability to be able to move in and out as needed. Any questions?
What sort of age are we talking about? Are we talking about infants, and is there a percentage?
Okay, so yeah, so young onset dementia is anything that's under 65. Generally speaking, you'll find that nationally they say that the diagnoses are between kind of 30 and 65. However, that does take account of the fact that within that you've got subsections. So you have got learning disability, which will often be quite young. You've got some specific disorders that will also go through neurology. They all tie into those kind of diagnostic figures, if you like. Certainly from what we see in our own services, generally speaking, the people that are coming through our services and maybe having a diagnosis are in the kind of early to mid 50s up to 65. That tends to be the more realistic kind of young onset dementia that we see. Statistically, I believe it's something, I might get this wrong, it's either 7 or 9, and I can't remember which it is, but it's either 7 or 9% of the diagnoses of dementia are young onset dementias. But we feel that that's probably underreported because, as we're saying, not necessarily, people aren't necessarily accessing those diagnoses in a timely manner. So it possibly is a bit higher than we think. Within our services, though, what we noticed, as I say, prior to this, and one of the bits of work that we've still got to do is that we now want to recrunch the figures to see whether it's made a difference as to the numbers that are coming through to us and the proportion of those that are actually receiving diagnosis. What we found was prior to this that literally, I think we looked at maybe 50 odd people and there was only 2 of them that actually had a diagnosis. Many of those others had functional issues, had depression, so it is really important that those other people get access to those other sort of supports in a much more timely manner, which is why we've put this in place.
You talked about a lot of people who are younger still working. Do you do any sort of in-reach work with employers and education around supporting people to
So currently we don't, because we are very much the diagnostic part of things. But this is all the stuff that I'm talking about where we'd want to work with partner agencies and things. So absolutely, this is stuff that we need to grow. So we do need to talk with, as I'm saying, Alzheimer's, Dementia Forward, they're all really forward thinking about, what can we do that's supportive. So absolutely, that's stuff for employers, that's stuff for but what I have actually found is that with the people that I've worked with, one of the things that has been really encouraging is that actually people's local employers and occupational health departments and things like that have usually been very, very supportive and helpful of people, even before a diagnosis is given, because they're recognising this need, this growing need.
If you're obviously looking at helping with the diagnostic side of things. So I run a charity called Hidden Disabilities. So we're dealing with people
Sorry, called
Hidden disability.
hidden disability.
So we have a lot of people with brain fog or degenerative conditions or all sorts of different things like that. So it'd be very difficult, I think, for them to know the difference if it was dementia or if it was just something that was happening. Would it be helpful, because we have a LEAP group, which is lived experience advisory panel with all different conditions, would it be helpful to get them involved? So you could be asking the questions direct to people with different conditions and how it might help with the diagnostic side of things.
I mean, potentially, I think the difficulty you've got there is I think what it would probably be better for is the other way around, as in I think it would probably be more helpful if we came to try to educate on what would be the things you need to be looking for. You know, if you are within these populations where you have these type of difficulties, what subtle changes might you be looking for? What things might you be, might be happening for you to think that you might need to have that checked out. With regards to the people actually coming through to us, one of the things that we will be looking for as part of that is this brain fog? Is this, do they have a hidden condition, like you say, or a long-term condition that actually is probably the underlying reason for their presentation? And so without going into too many details now, because obviously I'm aware we're time limited, but it might be worth coming to talk about those types of things because, there will be subtle changes that might happen, but certainly, there needs to be a balance with the fact that could be normal pattern for their condition. So that needs to be us coming to educate, I think, possibly.
Got one time for one more question.
Karami's got his.
Now, just reflecting, this is a really, really important piece of work you do. I think the reason is because dementia is seen as an irreversible diagnosis, and it's psychologically, even the concept that you go in for dementia diagnosis can be psychologically challenging for patients, even when they get to the end and you say they don't have dementia. So right at the beginning, triaging them into the right place to get the right treatment quicker is so important. I'm looking forward to, in another presentation, to see how the numbers look like. So if you're getting 50 referrals and only 2 of them or 3 of them, then it means that all the pathways need to be looked at in a good way. This is so important that I'm thinking that this could be an important research as well. So think about it. I'm not giving you another work to do, but this could be an important research.
Yeah, agreed. Totally agree. Yeah.
Thank you.
Can I just ask, do we have any questions from our virtual audience?
Not at this point, no, but could we just ask, just for the benefit of those that are watching online, if you have any questions, if you just put your hand up and then one of us will try and get to you as quickly, just so we can give you the mic, just to allow people watching online to be able to hear everything. Thank you.
Thank you ever so much. Some excellent work going on. Thank you. So next I'd like to introduce you to Lee Rickles. Lee is our Chief Information Officer and the Director and Deputy Senior Responsible Information Officer. And he's going to come and talk to you all today about the Innovation Hub.
Yeah, and that was easy for you to say, Mandy. Based on the timing, how long have I got?
You've got 25 minutes.
So still sticking with 25.
Still sticking with 25.
Okay, that's fine. Just wanted to make sure that I wasn't going to get the finish early because we're, let's spend our time as effectively as possible. So yeah, thanks for the introduction. Okay, so as Mandy's explained, I'm going to be talking about the Innovation Hub. Now, the Innovation Hub, although I'm here speaking about it, it's a piece of work that's been done as a trust-wide initiative. I just ended up being the lucky person that would come and provide a bit of a briefing, bit of an explanation of what we've been doing, where we've got to so far, what an Innovation Hub is, because we can't just make the assumption that everybody knows what all these things are. And the real thing, as it says, it's really cultivating them ideas and making a real impact. Whether that's around quality of care, reducing our costs so we can spend the time and the monies more effectively, any of them type of things. So starting off, what is an innovation hub? So basically, it's an ability to create change. It's that catalyst, and generally, it's dedicated space, dedicated location where you can have a diverse group of people, and when I'm saying people, that's patient carers, professionals, administrators, technologists, anybody who was actually part of that particular idea that you're looking for innovation or looking for the options of innovation. Because sometimes, unless you understand the lived experience that people are going through, whether that's carrying out your role, how you're living with any particular health issues, or just your daily lives, because daily lives still go on, whatever happens, understanding what a change would mean, what an innovation would be, because innovation does mean different things to different people as well. But doing it in a structured way. So we are at an event that's had quite a bit of focus on quality improvement, and quality improvement is a well-proven tool to create change, to create a different mindset, to create a culture of change and learning, because learning and change and innovation is extremely important in a way that means we're constantly improving, and the improving bit is really important, because change in its own right can be quite destructive. If it's not managed effectively, can be quite demoralising. So the key bit is to do it because there is a need. It's something that is a very clear requirement. It improves the overall experience of the people that are involved, and also we can have a way within the hub of generating them ideas. Because again, there's always lots of ideas. I'm sure if so you all have lots of ideas every day. The issue is what ideas do we need to put the effort and time and resources in to create innovation. And again, it's the experimentation, it's the creating the culture. So there's the innovations that people come up with, there's ideas people come up with. How do we test them? How do we experiment? How do we test the research to make sure it is actually being effective? What's the outcomes we're trying to get, and are we getting there? Rather than, again, as I said, change for the sake of change. And sometimes when we're looking at innovation, it's quite difficult to quantify innovation. 100 years ago, if I would have been saying to an audience, how do we want to get to America faster? They'd probably say, can we get that ship just to do a few extra knots and get there a day earlier instead of being 5 days, 4 days? Rather than in this day and age, we'll be saying, actually, we just want that, why can't we get over there in 4 or 5 hours by actually flying? So, it's that jet planes, and, I'm sure in the future we'll have something about Star Trek teleporters. Maybe not this year, but it's that idea of what do you class as innovation and change. So it's rather than faster horses, like the ship, it's jet planes. How do you think a little bit more bit more forward on things? So what does a hub do, and how we do, and how we're looking at where we're going around? So how do we get the ideas to having an impact? We need to create ideas. We need to have a way of submitting ideas, because just because you create an idea doesn't mean a member of staff could have a brilliant idea, but they may not have the resources or the skill set to make it impactful. So it's got to be you've got to have a way of actually filtering them and being able to assess them. Technology is pretty good at that type of thing. We are in an age of technology, but it should be an enabler, not as a barrier. Sometimes technology can be a big barrier, especially when it's poorly used or poorly considered. Also, supporting refining ideas, using workshops, using mentoring. Funding is always a key one for getting things up and running, whether that's R&D monies, whether that's funding that's coming from a national perspective, or just reinvestment internally. Without that funding and resources, innovation generally doesn't happen. Another very important one is project management. Do we make sure we're actually delivering it? Are we keeping it on track? Do we make sure it's being executed well? Is there a good oversight and governance? If there's a very clear clinical or patient carer activity, how holding the project to account, it makes absolute sense. And then there's a bit where we should benefit as well, where benefit from other innovation hubs for where they've implemented and where we're getting learning from them, but how we disseminate what we've learned and share that with others. Because again, it's not just a trust, it is the wider system. There's generally in supporting anybody who's receiving services from health and social care, there'll be multiple providers and multiple people involved, including the carers that generally are far more involved than anybody else in the process. Empowering. So the key bit around innovation is giving headroom, providing the opportunity for that development. How we can look at where we've got service planning. So we always do it around the service planning. The service planning should be informed by needs and requirements and understanding where we need to develop and empower. So that's from a staff point of view. From patients, we've got to look at better care. I mean, it is all around patients. That's the only reason we're actually here, patient and carers. There is no other reason for this organisation to be here if we're not doing that role. Absolutely important, and there should never be an innovation that isn't linked to either improving the benefit to patients and or carers. But again, they are part of the innovation hub. They are part of what we should be looking for around where's the opportunities, where do we need to focus. And also we do need to look at efficiency. I put efficiency there. We could say quality. Quality always drives efficiency. If you get it right first time, you know what you're trying to achieve, you will get the efficiency savings, you will save cost. Any effective organisation that's really focused on quality will deal with the other items. But we are in, if anybody who's listened to media, efficiency and productivity are the key words. The nice words, but the quality bit is the key one. So, what progress has been made? All very grand words. It's a bit of an overview of what an innovation hub. As a trust, we've spent quite a bit of time considering how do we work. We've spread across a very broad patch with the services we provide. We've researched how other organisations have done this, including whether it's that's academic or health and social care, to try and inform what innovations out there and how we would operate. We do have a task finish group. Again, I'm one of the members of that group. Kwame, our medical director, Kwame Fofi, is the executive lead on it and takes it very seriously and does hold us to task. We've also recruited people into the team, so we have actually recruited into the QI team, but from an innovation hub capability, because you've got to have some people, you've got to have some resources to actually make this happen. It's not going to happen on its own. So the organisation, we have invested in staff. The initial focus is really how can we do a level of this virtually, because we've got so many staff spread across so many different sites and so many patients spread across, North Yorkshire, East Yorkshire, Hull, and around them areas. To try and get that innovation to really get going, the aim is really to start using how can we do a level of that with a platform, very techie term really. You could tell I did the slides really, somebody else who might have put something. But how do we create that environment so we can work together, whether that's using online tools, sort of touching back on the conversation was mentioned earlier about the video conferencing, that type of stuff, but also create the ability to chat, communicate. So think Facebook, but innovation hub, but probably without the cats and all that type of stuff. Although cats are an option if people really want to have them in the innovation hub and they add value. To really get that IG generation and way of focusing where we're going. Although we're going to have lots of ideas, we do need to use the tooling and the systems to be able to determine where we would put the most effort, either because of our organisational objectives, which are based on the health needs of the regions we serve, and also what the bang for the bucks is. So how quick can we make a difference? It's no good, we've got a really great idea, but we're going to be 4 years away. I mean, 4 years is a long time, especially with how practice is changing, how new drugs are being released to market, how research is coming in to inform other practice. So again, there's that concept of where it would make that big difference. And it really is building on the QI process. So it's really trying to pull all the really good stuff we've already got on quality improvement, but try and focus it so we can focus the innovation. Because some of the quality improvement we have, although it's really good, it's a bit like, is there any cyclists in the room? Anybody who follows his? Okay, I won't use that example, but it's just small changes. So a lot of staff will have a really good idea on change management and quality improvement that this change will make a difference. These small changes make differences. And then marginal gains are effective. In industry, that's Toyota have been really good at that type of stuff, and it has bled out to the rest of the world, to be honest, as lean thinking. But then you've got the big changes, and that's the difference between can we make that boat go a little bit faster to actually can we actually get to the US in 5 hours rather than 5 days type thing. And that's looking end to end, so that's as much around the patient experience, the benefit to patient and carers as much as it is professionals and everybody else. As that it might sound, just being able to manage our pharmacy budget and medication just saves money, so then we can reinvest in other ways, so hidden things. How to get involved? So we're still really at that task finish group, and we are coming together, but the key bit around an innovation hub is it needs everybody involved in that innovation hub. It's not just trust staff, that is where we sort of started to try and get the momentum, but it's got to be focused around the public, patient carers, the technologists, the professionals that provide care, the healthcare professionals, the assistants, the administrators, everybody who's key to create that change. So by getting involved in ideas, when we've got it up and running, we'll be able to do that, so it will be available for ideas to come from anywhere. So that will be in the web, and there'll be that will be going out and explained. We've got workshops and events like this, but the same thing will start coming from the Innovation Hub. And just where we buddy up, because obviously there might be particular themes or areas we want to go through based on the ideas that come in to the hub. Becoming an innovation advisor. So this is a concept where you can end up with a challenge that people who live innovation all the time lose the real world contact. So having advisors to keep people on track, to consider what innovation really means to them, how that really has how is that impactful to my son who I care for, or myself who has health issues, or realistically, that type of thing. As much as from a practice point of view, if we do it this way, it means this. If we do it this way, it means something completely different. Or even, please don't give me loads of tech because it's just not going to work for me, for instance. Give me loads of tech because I really want to do it. Everybody's different. And how do you contact the hub team? I haven't got the contact details there. We will share post the event. I do apologise for that, but we'll get that information out so the hub team can be contacted for anybody who wants to ask for any other questions or does want to get involved in the development of the Innovation Hub. So hopefully I'm doing okay for time, Mandy and Kath. So really it's questions. I will ask other people who are part of the Innovation Hub to answer some of the questions if there's some really, really complicated ones.
So I was just wondering, like as a trust employee, what would be the distinguishing thing? What would be the distinguishing factor as to the type of thing I would bring to an innovation hub versus the type of thing I would just get on with and do as a quality improvement thing at local level? So
initially, there's probably not a great deal of difference. So from a local level, you may have aids in innovation, do a QI, do the charter, and do the. But then the issue with the hub is how do we create the visibility of what you've created from a QI point of view, and is a level of that transferable to other services? So have we got an innovation that we can spread and share and build upon, rather than we've got a QI piece going in here, but we've also got 4 other QI pieces that are all very similar, so we can either pull them together. So the issue on like triaging, looking at how we do some level of diagnostics, going through a process, or even the technology tooling. So for instance, using the video conferencing or other solutions, because that could be some type of avatar on a telephone, or it could be actually, you know, some of that could be where the innovation hub really comes in, because you can see either the cross themes that say actually we need to do a bit of an innovation piece here because there's a general need, there's a general requirement, or actually don't redevelop that QI in them other areas. We've already got something here, let's work with that team and then create the spread. So that's the difference. So we're not creating siloed incremental change in teams, we're trying to spread, and that might be within the trust, but it also might be within the region, or it might also be nationally, where we have got some technology example. I'm sorry, I know this is on technology obviously, but for instance on some of the stuff we've done from a technology point of view, that's spread to 8 million of the population of the UK now from the original 1 million we started with. And basically it's been done because it's far cheaper than suppliers doing it, and it's using modern technologies to share data basically. But it's building on that, but it's knowing they exist, because a lot of the time people aren't cognizant of there's something else going over that side of the trust, and that's the bit of the virtualness. Because we are spread so greatly, sometimes it's really hard to create them hooks where we might have a better achievement if it was in a hospital environment, having a room and space, and then it's all co-located. So long answer, but that's where I'd see the benefit. But that's why we need resources in the Innovation Hub to help try and link them bits together as well. Because if we just hope everybody can look at things and check, like, you know, everybody reads the website and the intranet, well, probably not to the detail they should. It's connecting them hooks. Hopefully that helps. Yeah, that's right. Yeah.
Do we have any questions from our virtual audience? No. Okay, thank you. Just to say that if anybody has any questions about the Innovation Hub, please could you direct them to the Quality Improvement mailbox, the Q Improve mailbox, and we'll be sharing all those details at the end of the event with the slides.
And if anybody does want to get involved in the Innovation Hub, as well as quality improvement, the door is really open to it. It would be absolutely invaluable to have that input from patients and carers. It really would.
Oh, I think Marilyn's got a question.
Okay, Marilyn.
Thank you. Just thinking about innovation hubs, I know that I've sort of looked at them throughout the country. I mean, they're not, it's not just here. This is
No,
new.
they are, yeah.
And one of the things is that they will be interconnected too. So whereas there might be some really good innovation, say in Plymouth, then it will, if it is feasible, it will go through to the other innovation hubs as well. So it's like a joined up space. It's not in silos anymore.
No, it absolutely isn't. So our innovation hub, we are linked in with our integrated care system, but we're probably slightly ahead of where they are. We are working closely together. We've got extremely close links into Health Innovation Yorkshire and the Humber. So Richard's mob, Richard's team, who also do a lot of used to be the academic health science networks. They also have a hub that links across that way. From an NHS perspective, there is also there's a best practice blueprinting sort of group, but that's more of documenting and research rather than the innovation of the doing. So there is a clear link to make sure we get that spread. Because again, one thing the NHS needs to improve upon is sharing that good practice and expertise, which historically it's been not so good at, but also doing it from an evidence base that shows there is really value add. And we're getting a level of that on the air. I mean, AI is a big buzzword at the moment. Everything's AI. You know, if I had a penny for every supplier that rang me trying to flog me some AI stuff, I'd be a very, very rich man this week. But that's another example where it will tie into Innovation Hub, but what type of technologies would be supportive? Because AI in its own sense is a waste of time. It's got to have a need. And that's where, again, that spread at the moment, that isn't quite happening as much as it could. That's one that people are catching up on. So you're absolutely right. So, yeah, yes, it is linked.
Thank you very much, Lee.
Okay.
Thank you. Okay, next, please could I welcome up colleagues and our patients from our Forensic Services Division. Would you all like to come up together? We've got three shorter presentations all rolled into one for our next section of the agenda. So I'll hand over to you all. Thank you very much.
I'm Lucy Wilshire. I work on Swale Ward, which is our specialist division for those with personality disorders. Last year, we were invited to join the Culture of Care project within NHS England, and it was quite a big honour for us, to be honest, because we weren't expecting to get it, but within the project, it aims to address the culture within the ward across staff and patients, obviously to create a therapeutic space that feels safe and fulfilling for everybody involved. We actually got awarded the co-collaboration stamp last year as well, which was a massive thing for us. Within the project, we're looking to introduce 20 QI projects over the next 2 years, which have been co-produced by patients and staff to benefit both equally. The culture across the wards, it's been a bit off balance for a while as far as I'm aware, and over the next 2 years we're hoping to massively change that to make it more collaborative. So these are just some examples of the practices that we've been trying to introduce. So I'll go through a couple of them. The tribunal teaching sessions and the doctor Q&As have been really, really valuable for the staff in particular, because it gives the ward staff that opportunity to speak directly with the doctors and kind of bridge that gap between the higher management and the lower on the ground staff, as I refer to myself as well. And with that bridge, we are able to have a better understanding of our patients from a more experienced place. So it just enables us to care for our patients better. Our ward community meetings are, again, co-collaborated. The patients are always invited to come along, and it's usually really, really well attended. We discuss things that happen on the ward, things that have been going well over that month, things that haven't been going so well. The racism awareness and the EDI projects, one of which Yvonne's going to be talking about later, they've been really, really appreciated because we have quite a lot of international staff on our ward, and it's nice to bring that together and make it a community. And the co-produced activity planner has been created with our patients' own interests in mind. So they've come to us with suggestions for what they'd like to do with their time, and we've managed to filter in a several section weekly planner that allows there to be an activity through each part of the day to make sure everybody has their interests and needs met. We've also created a staff survey with the intention for that to be completed every 3 months, just to keep an eye on what's going on as part of the plan, do, study and act method, just to make sure that we're on the right track and to keep things progressing in the right way. Within the culture of care, this is the standards that we are aiming to meet over the next 2 years. Again, I won't go through all of them, but the lived experience side, we do have several of our patients involved in expert by experience roles, one of which was hoping to be here today but couldn't make it. Actually, 2 were supposed to be here but couldn't make it. Creating an atmosphere of staff support and equality, making sure that everybody feels heard and feels welcome across the ward is one thing we're really, really striving for on Swale. And as I say, with the act plan, do, study and act model, we're making sure that everything we're doing is actually achievable and accomplished within a timely manner that we're aiming for. It's been really, really fulfilling for us on the ward to make sure that everybody has a voice that's being heard and everybody who wants to be involved has that opportunity to get involved. So, thank you. Any questions? No. Thank you. Thank you. Right. Thank you very much.
Thank you. Now, can I introduce Paul, John and Ben, who have bravely taken on this presentation. Unfortunately, the ward manager who was going to be coming and leading on this project and on this presentation has been unable to come today. So these guys have actually been brave enough to step forward and do this on their own. So
my name's Paul. I'm a service user on Rosewater.
Sorry, Paul. Why might it go?
Clicking the white button in bar.
Oh, right. Sorry.
It's all right.
Oh, there we are.
I'm just saying about there's three of us. I'm going to be first. My name's Paul. And John's going to be second. Ben's going to be third. We just said to this yesterday what we was going to say. So it's been short notice, but we're doing quite well. Also, there's a medium school learning disability ward based at the Humber Centre for forensic psychiatry. So that way it is. We have 10 beds. So it's 10-bedded unit. We are a male unit, and our service users all have a signature of learning disability or autism. Now I'll pass you on to John.
My name's John Nicholson from Rosewater, Humber Centre. The team attended our event in summer 2014 to learn about the aims and subjects of the Mental Health Act Quality Involvement Programme. The team then had informed an improvement day to decide on what the ward would focus on, this including service users.
Do you want to do this one as well?
No. Yeah.
Yeah, can you read that one?
Members of the MDT came together to complete our specialist day. This allowed the team to highlight areas that we thought that we could focus on, could finish on, including experience and by experiencing the decisions.
Thank you, John.
Yeah, we all meet. Let me just restart that again. I'm so sorry.
Ben, you're doing great.
We all met and discussed that our goals would be better to develop the relationships and understand together better improvement, meaningful activities for our services on the ward. For examples, our IQ team had met weekly to improve more forward with our projects. The team has been made up as of a variety of different MDT members. The project has also had support from our exclusive members of the director within the team and the trust.
Do you remember this bit? I've it on here.
I've forgotten it.
You're all right, no problem. See, what they've actually been doing is working together to look at following the discussions that they had on the ward. You have a coffee and chat weekly now.
Every Thursday.
Where staff and patients get together and talk about what's meaningful activity on the ward and how can they improve meaningful activity. And you've actually looked at, haven't you, having education sessions so that not only staff, but service users and patients on that ward are educating together about what meaningful activity means to those people on that ward. You're developing planners, aren't you, together in that coffee and chat team day and team meeting, so that the ward is working together to look at putting up activities every week that has meaning to the people on that unit at that time. And that you keep getting feedback, don't you, and changing those goals as you're going forward.
So like every week.
Every week, yeah. So like I say, at the moment, it's in the very beginnings, but they're hoping that it continues to improve.
In the very early stages as well. Yeah.
Thank you, guys.
And also perhaps...
What do you want to say, Paul? Can I just take you back? I know what Paul's going to say. How do I get back? Just to show you the badge.
Can we ask at the back, please? Could you take us back? Yeah.
It's just right to the beginning slide.
Yeah.
That one there.
This is a picture what was designed by staff and patients on Rosewater. Now, lastly, you have me, and unfortunately, the person who put this presentation together is also unable to be here today, but he's entrusted me, and I've got the privilege of sharing this presentation with you today. This presentation, I suppose, hits two things for us as a forensic division and how we actually develop improvement and quality improvement within the services. This presentation was actually delivered to our senior management team and has led to many changes. Nathan, actually, his first impressions when he came to the service around equality, diversion, inclusion, and what it means to him are actually looked at within this presentation. The 9 protected characteristics and the improvement recommendations he put together following his journey.
Yvonne, would you just stand in front of the microphone for the virtual audience?
Sorry.
Thank you.
What Nathan shared was on his observations when he first came to our service was that the Humber Centre was lacking in the vital access of information in regard to equality, diversity and inclusion. He could see no posters, no leaflets, there weren't any newsletters around or signposts to any relevant support, particularly for service users. There were no groups for those who might need a safe space to air any issues, and ward staff and patients were making hurtful comments at the time, was what his experience was. So what did he do about it? Well, when he first arrived and he couldn't find any information, he went digging and he asked other patients on the ward about their experiences and whether they knew were there any groups around for somebody who had LGBT requirements. Nobody knew that there was anything around. He then actually went to his first MDT and got some online access approved, because within our secure services, unfortunately, some of our patients don't have access to IT straight away. It has to go through a process. When he did get that approval, he actually started looking at our trust website and looking at what the policies were. And he found the website was quite difficult to navigate, and he also found that it wasn't very helpful when it came to patients, because he couldn't find anything really around EDI that was specifically for service users. Then he attended our patient council, and he raised issues there and was unable to get clear answers from anybody really about what the understanding of the policy around EDI was and exactly what was available. So then he came to me and we had a discussion about what he could do. And I suggested to him that maybe he could lead a piece of work and look at what patients needed and what kind of policies we needed to put in place. And he accepted that challenge, and that's when he actually put this presentation together. And he presented this to our senior leadership and our senior management teams. At the presentation, I won't go through his story, but at the presentation to the senior leadership, Nathan actually went through his journey within our services currently, what his good experiences have been, what his bad experiences were, and where he is now. He then actually did some training with our senior leadership team, and he actually talked them through what equality, diversity, inclusion meant to him, and what it means in regards to the characteristics. And he actually went through a process of talking through all the 9 characteristics and how some of them were affecting him as a service user within our services. Following this, like I said, I won't go through the 9 characteristics. He then made some recommendations. Those recommendations were to assemble a project group of patients, carers and staff. He did a literature search of current standards and existing policies in other services, to look at requesting posters, flyers and leaflets to be produced, particularly with the aim of focusing on service users, to provide digital information to be produced for TV screens that all our wards within our forensic division are actually getting digital screens where information will be displayed. To produce content that can be uploaded onto the Trust website that was accessible, and to establish what groups and support are needed within the Humber Centre and Pineview services, and to develop and distribute a questionnaire across all platforms for staff, patients and carers, and look at training opportunities for staff and patients in regards to EDI and their role within it. To produce a calendar of events celebrating multiple cultures, faiths and minority groups, and that we review that yearly. To highlight one event a month in conjunction with our catering themed food nights, so that we could raise awareness around that kind of event. Currently we're looking at Ramadan and learning about Ramadan within our services. And the theme night at the end of March will be about celebrating Ramadan. Raising awareness of the importance of EDI, the introduction of a discrimination incident report form that's available for patients, staff and carers, so that they can self-report any experience that they've had. To actually consider getting the thoughts of the police liaison and the Trust Equality, Diversity and Inclusion lead, John Duncan and Sue, who's part of our group now, in regard to the law and equality and diversion and inclusion, and to approach other staff, patients and carers to share their stories. Before I go ask for any questions, what this actually led to, following the presentation, was Nathan actually now leads and chairs a task and finish group that we're actually looking at these recommendations and going through them stage by stage, looking at developing certain resources that will actually help support EDI within our services. We're currently in the process of developing an information card that can be a handheld card that gives information about who they can contact for different areas of need. We've also got an event that we're preparing for on March the 25th, where we've got external stallholders coming in, and we're focusing on an awareness session of equality, diversity and inclusion within our services, and we're inviting patients, carers and staff to all attend that event together. We've also, alongside that, produced a questionnaire that will be going out to staff, patients and all our carers and family members around EDI, so that we can get a baseline of what our population knows about equality, diversity and inclusion, where are the gaps in knowledge, and what information and resources would they like to have in place in the future. And that questionnaire and survey will be going out next month in preparation, hopefully, for our event on March the 25th. Thank you.
Yvonne, would you hold there for a minute? 'Cause I think there might be some questions. Has anybody got any questions that they'd like to ask any of our colleagues and patients?
I'd like to know what sort of meaningful occupations and activities that people came up with that you were already doing on the unit.
Do you want to, can you speak about that, Ben?
Yeah, I'll speak a bit for you.
Yes.
Well, basically, it's like we've got, like, at 1 minute, like at one point, we just used to have minimal activities on the ward, but now we do like shared lunches on the ward, where one patient would cook with a staff member to do it for all the patients on the ward, with maybe for the staff as well, if they wanted it. Like we do like maybe your film group, or where we used to do like karaoke sessions on the ward as well. And I'm trying to think of anything else. Oh yeah, we've got like a games room where we can use like a PS4, or pool sessions. We can do like jigsaw sessions, art sessions. Thank you guys. thank you very much, Rachel, for that one. Bingo sessions as well. We've got the gym as well down in the sports hall, where we've just had that developed. How long ago?
It's about a year, isn't it now? It's a brand new gym, haven't we?
Brand new gym. It was originally a swimming pool area, but what was not being allowed to use because of money situation. But now we've got it as developed as a full functioning gym. And anything else?
I think a lot of it is we're looking at people working in the shop now, aren't they? Having work experience within our on-site shop. And we're hoping, aren't we, in the future to develop more voluntary roles within our service, looking at what opportunities vocationally can be available as well. Because we're looking at computers, aren't we? And the use of IT.
Mini iPads and all.
Yeah, that's right. That's right. Well done. Thank you, Ben.
Woodwork.
Woodwork as well. Yeah.
As well.
Thank you.
Brilliant. Virtual audience?
Thank you. It's not actually a question, but it's a comment that's come through from Rachel McGarry that says, "Thank you, Forensic Service Division. Your presentation really showed patient involvement and co-production in action, and it both inspires and challenges me to identify and create more opportunities where I work."
Oh, that's really nice to know.
Brilliant. Thank you so much, all of you. Absolutely fantastic. Kath's got a little thank you for you that she'll give you at lunchtime to the patients. Okay, so we've now come to the final part of our morning agenda. I'd now like to welcome our Chief Operating Officer, Deputy Chief Executive, Lynn Parkinson.
I've got the pleasure of wrapping up our morning session, and I'd hope you would agree with me. It's been brilliant. In fact, I couldn't use too many adjectives to describe it really, so thank you so much for that. So I guess just to bring it to a close, just reflecting on what we've heard today as well. So we started our session with Dr. Almar Shah, who's the National Clinical Lead for Quality Improvement. It's a shame that he couldn't have been with us in person, but a few of us have met him actually, and he is really impressed with the work that we're doing across the Trust. He talked about a few things, didn't he? Really about how we connect quality improvement and patient and carer experience, that co-production. I thought that came across really strongly. And personally, I have personal passion for all of this work, but I think it's so great that we're now bringing that patient engagement co-production absolutely together with quality improvement. And I think he said it, didn't he? You cannot do it. You can't do one without the other. They absolutely have to work hand in glove. So great to hear that from him. Then obviously we had those reflections from both Mandy and Kath as well, just really cementing sort of that work, why this work has to join together in the way that it does, and to hear about the plans for the future, sort of where we are now, and really where we hope with all of you to sort of go next with this really important work. Then we had Dr. Matola from Avondale, who gave us that example of quality improvement in practice, you know, particularly around the improvement in completing those discharge summaries. I thought the questions were great around that, but it absolutely does make a difference to our patients as well. And I think those examples that, well, actually, we don't do that in a timely way when you're discharged from hospital, that just causes you problems. I think you explained that really well, Kirsty, as well. And then to that great work that we heard about from yourself, Kirsty, around young people with dementia, a really important and really fascinating area of work. And I think Kwame's comments about research opportunity, is not to put you under pressure, but I thought that was really helpful as well. To our forensic services, what a brilliant presentation as well, and I really have to thank Paul, John, Ben. It's not easy to stand up here, but you did it brilliantly, and I think the comments from the chat said it all as well. That work that Nathan, so will you please, Yvonne, take back our absolute thanks to Nathan. That's a brilliant piece of work, isn't it? And again, real opportunity for the service users in the Humber Centre, but absolute opportunity to share that across the Trust as well. So fantastic work. And then obviously sort of with Lee and his description of, again, where we're hoping to go next as an organisation in the development of that innovation hub. So hopefully he's tempted you to want to be part of that and to participate, because the bigger network that we grow around that work, then the better results and outcomes that we'll have in terms of improvement. So I'm going away from this morning session. I know we've got a brilliant session for this afternoon as well. So I really hope you do stay with us for that. I'm sure it will match what we've heard so far. But it is lunchtime now, so obviously we've still got the stalls out there. So if you've not had chance, because what you'll see is an even bigger breadth of the quality improvement work that we're undertaking at the moment, and those examples of how we're continually engaging our service users and carers in that work. So I think we've got an hour-ish for lunch. So back at 1:30-ish, we'll give you a call. So I'm sure you'll all be involved in many communications over and conversations over lunch as well. So thank you again. It's been a brilliant morning, and I'm sure the afternoon will be too. Thank you.
Room now. Lunch will be served between 12:30 and 1:30. So if everybody can come back at 1:30. Our virtual audience, if you can all come back at 1:30, please. Thank you all very much.
Hello, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 2, 3, 4.
One.
Okay. Yeah, kind of. I'll put here.
How are you doing? I'm good, thanks, Kat. Good to see you.
I know, fine. I know.
We're starting. Hello. It is Mandy. Welcome back, everybody. Hope you managed to find something for lunch. So just to get us started for the afternoon, I'd like to invite Acho Alendu to the front. And Acho's from the Humber Recovery and Wellbeing College. He's a practitioner there, and he's going to do a little bit of Tai Chi with us. So please do join in.
Hello, everybody. How are we all feeling today? All right, cool. So we're going to do a little bit of Tai Chi today. So I've got, is it 10 minutes, did you say? Okay, hopefully I can split it up between stood up and sat down. So is everyone okay to stand up? No? Brilliant. Oh yeah, the camera. Oh yeah. I think the camera should be all right there. So, just maybe, okay. pop your hands out like this. Have you got space around you? No? No? Yeah, brilliant. Oh, brilliant, brilliant. Right. So what we're going to do is going to do some Tai Chi, but we're going to be stood still in this position here. So we're not going to be moving up and down because one, there's not enough room, and secondly, it's a lot easier to remember. Okay, so the Tai Chi we're doing today is Tai Chi Chuan, but this is stood up Tai Chi, but stood in one spot. So, few fundamentals first. Firstly, make sure your feet is flat on the floor from tip of your toes to your heel. Make just a little bend in your knees so that it aids in movement. Next is posture. So, lumbar area. I want you to pull that in. Naturally, your chest will come out and your shoulders would lower down. And relax. Brilliant. Breath work. I know. We're going to breathe in through the nose, but we're going to belly breathe. We're going to send our breath all the way down, just to below the belly button here, called the dantian. As we inhale, our stomach expands. As we exhale, it contracts, but our chest remains still. So we don't breathe to the top part of our lungs. We send it as far down as possible. Let's try that breathing now. So breathing in, expand your stomach, keep your chest from rising. Breathe out, contract your stomach, but keep your chest from rising. A few breaths of that. Now breathe naturally, nice and gentle. Don't force the breath in. Breathe out. One more time. Breathe out. Good. Good. How was that? Okay? Great. So we're going to use that pattern of breathing all the way through this short demonstration. Is that okay? Brilliant. So our first one is called rising and setting of the sun. So as we're stood, shoulder width apart, slight bend in the knee. Make sure you're always looking forward, never look down. Relax and try to focus on what you're doing and nothing else. Okay? So, breathing in. My hands are going to be here, right in front of my thighs here. Wrist slightly elevated, lifting my palm up. As I breathe in, I'm going to gather here. Breathing in. Begin to breathe out. Breathe in. Breathe out. Remember, breathing to the stomach, not the chest. Breathe in. Breathe out. Breathe in. Breathe out. Good. Next one is called pushing mountains, or tiger pushes mountains. So here, breathing in. Split. And breathe out. Point the fingers and lower the palm. Breathing in. Breathe out. Point the fingers and lower. Very good. And again, breathe in. Split the yin and yang. Push the mountains back. Good. Next one, the low hand monk praise. Out, breathing in, palm facing up. And exhale. One more time. Breathing in. Exhale. Very good. Now, as we breathe, whenever we breathe in, we're going to match our hand movements to our breath. So there's a connectivity between internally and externally. What I mean is, as we breathe in, if your lung gets full, your hands should stop. What we don't want to do is, lung gets full, you hold your breath, and your hands keep moving. It shows a disconnect between internal and external. So, same with the out breath. As we exhale, our hands will fall. But if we empty our lungs, our hands should stop. Everything in Tai Chi is a continuous movement. Nothing stops. A bit like our breath. Our breath, we're always breathing, always breathing. When we walk, we don't go, stop, and then breathe out. All we do, well, some people might, but we naturally integrate it into our everyday life. And so this must be the same as well. So clear your mind, relax. Think of nothing else but yourself right now and the movement that you're doing. So let's start this again. Now we're going to do what we did all at once, one after the other. Is that okay? All right. Smile, everybody, as well. Smile. Ready? Breathing in. Pushing mountains. Breathing in. Exhaling. Still exhaling. Breathing in. Good. Very good. Very good. Single tiger pushes mount. I'm going to show you one last move, then I'll do the equivalent sat down. Okay? So that at least you have that as well to do. So, hands are going to go up like this as I inhale. And then it's going to open up and end up here. Can you see this? It's going to come out this way. How's that? Coordination. Coordination is the big thing about this one. But don't worry. Remember, don't overthink it. If we overthink it, we start to try to break it down a little bit too much in our brains, and then we start to get confused. So, I would say, turn on, I don't want to see myself on there. So, from here, raise our hands up like that. Relax. Use the wrist to raise. As in said, the focus point on up is the wrist. So this hand is just hanging there. Up. And then we begin to open it up. My right hand will stay out. The left hand will just drop to my waist. Yeah? This hand is here, will come out in a half circle. And it's going to remain here. Then it's going to push through the center as if replacing what's already in this hand or taking away. And this hand drops here. Follow that. There you go. And push or press. Now with the breath. Inhale. Exhale. Keep exhaling. And inhale. exhale. One more time. Inhale and exhale. Very good. Very good. How do you? How was that? How was that? That was all right. Okay. How long left? Is it finished? Is it time? Couple more minutes. But I'll show the alternative sat down. Is that okay? So remember, when it comes to Tai Chi, the most important thing is to do the things that you remember and do them as often as possible. Do not get worried about the stuff you can't remember or that you can't do. Start small and start to build. So the sitting down one. Right. Nice and comfortable. So importantly, when you sat down, if you sat down, do not lean on the back of the chair. It promotes too much relaxation. Yeah. Your feet will come out, start to slide down the chair, and then you're in that ultra comfortable position. But what you want to do is you want to move slightly halfway up the chair, have both your feet flat on the floor. Both your feet flat on the floor, and in the exact same way, lumbar area, pull that in. Yep. And then arm will come down to your thighs, elbow will come straight in. The idea is to take away pressure from your shoulder so that everything else is just nice and relaxed. Okay? So I'm in this position here. Rising ascending of the sun, sat down, very similar. My hands will come up like that, and it will turn here. Again, everything is done with the breath. So the moment you do this, you inhale. As you turn over, you exhale. Remember, Dandien. Then inhaling. Exhale. Because we're sat down, we don't have the luxury of going further down. So what we'll do is we'll do like this, out, and then we gather or cup. Bring it in as we inhale, exhale. Now just focus purely on the inhale and exhale and the movements of your hands. That's it, relax. Pushing mountains. Split. And push the mountains back. Don't lock your arm out when you get to here. Always a bend in the arm. Point the fingers and lower. As you get towards your thighs, begin to gather or cup again. Up, split, and push. Fantastic. And the low hand monk praise. We're going to slip off the thighs here as we come this direction. So as you come here, you're going to slip off like that. Palm facing the ceiling. Looking forward, not up. Inhale and exhale. One more time. Inhale. And exhale. And then return the palm back to here. Okay? So, quick question. How many of you are still breathing to the chest? So don't worry about it if you do that. Just if you notice it, bring it back to the stomach and breathe to the stomach and out again. So create a cycle of inhaling to the stomach, out again, either through the mouth or the nose. Perfect. I think everyone was brilliant here today. Well done.
you. Thanks everybody, did you enjoy that? Nice and relaxed for this afternoon. So please can I welcome to the front Dr. Kwame Fofi. He's our Executive Medical Director and Responsible Officer, and he's going to be opening this afternoon's session.
Thank you, Catherine. I think it's obvious that I didn't get a memo about ATA. I would like to come in with ATA like Archie. So welcome back. I have the pleasure for being the Executive Medical Lead for Quality Improvement and Patient and Carers Experience Agenda. In plain English, it means that I stand on the shoulders of a lot of people who do the heavy lifting and the work, and to be able to represent the strategy for the trust. The ultimate aim is to help patient care and to provide good quality care. Hopefully this afternoon we'll see an engaging lineup of presentation that I'm sure you will find inspiring and informative. I have confidence that these sessions would highlight the remarkable strides that we are making to improve quality improvement in our services. And like I said before, to enhance the experience of patients, service users, and carers. Just want to thank everybody for your commitment for continuous improvement and your enthusiasm. Please enjoy this afternoon and let's take the opportunity to grow together. Thank you.
Okay, so we are going to now introduce you to our special recognition section. So, Kath and Kwame, you both here? Yep, great. Kwame, excellent. Okay, so this is going to be a recognition section to thank everybody who has dedicated time and passion to both the patient care experience and quality improvement agendas over the past few years. I've been in my role now for nearly 8 years. I know Kath's been in a quality improvement role for, is it 5 years, 6 years?
Roughly.
Yeah. And we've worked with many of you together and also individually over that period of time. And all patients, carers, service users and members of the public and partner organisations in the room, as well, of course, as our staff, thank everybody. You're all in the room today. You've all got a passion for patient and care experience and quality improvement. That's why you sat here today. So I want to thank you first of all, because you all need special recognition for supporting both of these agendas. But there's just a few people that we want to specially recognise for their outstanding dedication and effort. So I'm going to present a few speeches now for these individuals. So first of all, I would like to recognise Marilyn Foster. Marilyn has been a breath of fresh air for both the patient care experience and quality improvement agendas. She has a wealth of knowledge and passion for quality improvement and has been a great sounding board for Kath, providing advice and support. Since working with the Trust, Marilyn has supported numerous projects and initiatives, including being a patient lead for the Scale, Spread and Embed initiative, supported with the development of the current patient and care experience 5-year forward plan and film, Trust interviews as a panel volunteer, patient information leaflets, supporting with the development of the Innovation Hub and is a service user and carer governor and lead governor for the Trust. We thank you very much, Marilyn, for all you do to support the Trust in your various roles, and we really do love working with you. Please could you come to the front? photographs.
Thank you, everybody. Thank you.
When we have the next break, if all of our recognised individuals could join myself, Kath and Kwame, that would be appreciated for a group photograph. Thank you. The next person we would like to recognise is Jean Hart. Jean has been a valuable patient and care experience champion for several years, with a true passion for ensuring individuals have a voice and are supported to share their experiences. When the quality improvement strategy was developed, Jean played an instrumental role to share her views to support with the production of the vision. She's gone above and beyond to share her experiences of being a carer to improve services across the Trust. She has also got a wealth of knowledge and experience of recruitment, having held a previous role as a careers advisor. Jean's knowledge has supported with the development of various initiatives, including the panel's volunteer role and involving patient service users and carers in recruitment framework. Jean has also supported the Trust with various initiatives to support carers. Her contribution to Trust activities is varied and includes sharing her story at Trust meetings, supported with the development of the current patient and care experience 5-year forward plan and quality improvement strategy, supported numerous films, including our carers film a couple of years ago, service improvement initiatives, Trust interviews as a panel volunteer, patient information leaflets, training programmes, place visits, service user carer governor and volunteers for the Trust as well. Where do you find the time, all of you? Thank you ever so much, Jean, for all you have contributed and continue to contribute to the Trust. We can't thank you enough for all that you do to support us. And again, we really do love working with you. Thank you. Please. The next person we would like to recognise is, I'm going to get emotional with this one, so calm me down. I'm getting emotional with all of them. I don't know whether you're noticing, but I'm wobbling. Is Anthony Hoof. Anthony has dedicated many hours of his personal time to support the Trust on several initiatives over the past 7 years, following the loss of his sister a few years ago. Anthony has shared his lived experience at Trust Board, contributed to service improvement initiatives to support families, carers and loved ones following a patient safety incident. He has contributed to training sessions to support our staff when working with families. He has also been an active member of several patient carer experience forums and groups, which has enabled him to get involved in a variety of projects and initiatives. Anthony's can-do attitude and passion to support families following a patient safety incident has led him to supporting the wider suicide agenda, where he has been involved in workshops to support individuals who have been bereaved by suicide. He offered his time to support the Trust suicide plan and more recently became a service user carer governor for the Trust. Anthony's selfless attitude is truly heartfelt, and we appreciate all he has done to support everyone he has come into contact with during his time working with our Trust. We are so lucky to have you working alongside us, Anthony. A huge thank you from the bottom of our hearts. The next person we would like to recognise is Ruby Watson. Now, Ruby isn't on the, she's not in the room today, but she is attending virtually. So, hiya, Ruby. Ever since myself and Kath have led on the patient and care experience and quality improvement agendas, Ruby has been involved. She has gone above and beyond to share her experiences of being a carer to improve services across the Trust. This includes sharing her story at Trust Board and Council of Governors, being a lead for Scale Spread and Embed initiative, supporting with the development of the current patient and care experience 5-year forward plan and quality improvement strategy, supported numerous film service improvement initiatives, trust interviews as a panel volunteer, patient information leaflets, training programmes, police visits, volunteering, including more recently at the Market Wheat and Practice, supporting Susan and the team, and the list goes on. A heartfelt thank you to you, Ruby, for all the time you have contributed to our trust over the years. We love working with you and appreciate everything that you do for us. So to Ruby. Now, Ruby, we do have a bouquet of flowers being delivered to your house today. So from 3 o'clock, if somebody rings on your doorbell, that'll be the Trust coming into your house, not literally. And next time I see you, I'll give you your certificate. We'll do it face to face over a coffee. Okay. Now, finally, we would like to recognise the Humber Youth Action Group. The Humber Youth Action Group supports multiple projects that truly make a difference to the care received by young people and their families. Here are just 2 examples of exemplary work they've undertaken recently. The co-production of our brand new Children's and Learning Disability Divisional website, Connect, which involved 14 members being created as animated characters for 28 animations that they also completed voiceovers for. This was to ensure the key message about our services were voiced by young people for young people. 2 young people were also paid for as experts by experience for the project, attending all strategic planning meetings, which ensured the golden thread of co-production was embedded through the entire design. The group has also been involved with the CLEAR project, and these 11 recommendations were made, and Katie, one of our experts by experience, will work over the next 12 months to support the CLEAR project team to embed these recommendations. 2 young people as part of this project are experts by experience that have undertaken the Anna Freud neurodiversity training that they will jointly deliver with trained staff early 2025 to our CAMS staff. This will ensure our staff have increased knowledge and skills when it comes to caring for young people with neurodiverse needs and effectively support their mental health. Could I have somebody from the Humber Youth Action Group, please, to the front? Now, we haven't given a bouquet of flowers to the Humber Youth Action Group because we felt that they would have to split the flowers. That would not work. So we've got you a voucher to share with the group. Okay, so hopefully you can enjoy that at one of your next meetings. Thank you very much. Now, last but not least, events like this do not happen by themselves. We've got a lot of purple polo shirts in the room that have been an amazing planning team to support Kath and I along the way. And we've been planning for this for, believe it or not, nearly a year. What I will say is there's been one person that specifically stood out, and we could not have gone on this journey without her. She has guided us right from the get-go, and that is our events officer in the organisation, Gemma. So Gemma, please can you come to the front? It's our special recognition section, so thank you all very much for your support.
Thank you. So I'd like to welcome to the front Flick Haig and Anya. Anya's a member of the Humber Youth Action Group, and she is going to, with Flick's support, tell us all about a patient's perspective of the group.
Well, thank you. That's quite a lot to follow, isn't it? Lots of positivity in the room. So, first of all, I just want to introduce myself. My name's Flick, and I'm the Engagement Assistant for Children's Services at Humber, and I work alongside my manager, Bethia Dennis, who some of you may well know. So, my role involves ensuring that our services are listening to the voices of children, young people and their families. And one of the ways that we do this is we run a youth group which is called the Humber Youth Action Group. And this allows young people aged 11 to 25 to come together and share their thoughts, ideas and lived experiences to improve and shape our services. Over the course of the past year, I have supported the group with multiple rewarding projects, and there's going to be more on that later. Our relationships are mutually beneficial. We support the Humber Youth Action Group with training, job applications, uni applications, but also the group share that by becoming a member, it's also benefited them. So they have made new friends, grown in confidence, and they've also considered a career in the NHS. And on that note, I'm going to introduce you to the lovely Anya. So, Anya, can you introduce yourself to the audience?
Hi, I'm Anya. I'm 23 years old. I live in a small village called Hutton Cranswick, which is on the east coast. I live with my mum, Kate, who is here today. So, hi, Mum. I live with my sister, Summer, who is my older sister, who sadly can't be here today. My dog, Brie, and I have soon to be a new addition, Badger the puppy. But I still see my dad every day on a daily basis. So on the 23rd of June 2022, I was officially diagnosed with a rare genetic condition, which is called Wiedemann-Steiner syndrome. I am a level 2 creative media student, currently a student at East Riding College in Beverley. The groups that I volunteer for are the Nothing About Us Without Us group with Claire Atherton. I am a volunteer for the Young Health Watch with Sim Tomlinson. I am also volunteering with Community Vision with Dave Brown and Detty Tyler. As well as doing that, I'm also doing my work experience with them, which is going really, really well. Really enjoying it.
So thank you, Anya. It's obviously that you do lots and we're really, really proud of you. So can you tell the room why you joined the Humber Youth Action Group?
I wanted to join the Humber Youth Action Group to help people and to make a change to the services across the Humber and network to help boost my confidence and to also make new friends, which would also help me to engage with the community more.
Yeah, we love having you, don't we, as a member. So what projects have you been involved in since you joined the Humber Youth Action Group?
Since joining the Humber Youth Action... Get my words out.
Don't worry.
Since joining the Humber Youth Action Group, I've been involved in creating the animated character and video to help launch the new website, the Connect website. Linking in with this, I was also involved in the photography side for the Connect website. Just recently, a few of us from the Humber Youth Action Group, we got together and did a podcast with Mez Green from the Wellbeing College.
Yeah.
Recently, we were involved in a redevelopment or rebrand of the Humber Youth Action Group, where we came up with an idea of coming up with like a new logo and values where the group could follow their new values and make it more inclusive for everyone.
Yeah.
And as a group, we all completed a training course where we did bystander training, and that bystander training is to help those with violence against women and girls. I also got the opportunity to be involved in the NHS dentistry session with Sim Tomlinson from Health Watch, and we also got to be involved in the CAMS passport.
Well, I don't know how you've achieved that in 6 months, but you have. So, can you tell the room what are the benefits of joining a group like the Humber Youth Action Group?
The benefits of joining the group is that we got to learn more about how the services work across the Humber network. For example, this can be CAMS or any other service.
Definitely.
And another benefit is that it has definitely shown how my confidence has grown within the last 6 months of being involved in a lot more projects.
Definitely, and there's no stopping you, is there? So what is your plans for the future? What are you going to be involved in next?
I I have recently become an expert by experience, where I'm working and supporting the key worker service, where we are going to be creating an animation video about the dynamic support register, where I'm using my lived experience of having a learning disability to make sure that this video is right for the other young people.
Lovely. Thank you, Anya. We really, really appreciate you and all the young people that are part of the Humber Youth Action Group. And I hope that we've shown that in the room today. So thank you. Well done. Smashed it. Smashed it. We're going this way, yeah.
So I'd like to welcome to the front again Dr. Kwame Fothi, who's going to be talking about where quality improvement has made a difference.
Thank you, Catherine. I think if I was to do this again, I would probably do it as a rapid firing. So I'll bring those who have done the quality improvement and give them 5 minutes to share what you're doing. So this is a bit more of a celebration and to showcase some of the work that people have done to make a difference. I'm sure there are a few people who did the work who are in the room. So when the time comes for the difficult question, I'll be expecting you to raise your hand to answer some of the questions. So was anybody in this room who was involved in this work? So this is, so what we say in healthcare is that everyone has 2 jobs. You do your work and hopefully you improve on your work as well. And this is one of my favorite quotes. So everywhere, every job that I do, my intention is to improve upon it as well. And these are some of the things which QI does. The most important is patient experience. It increases efficiency, improves the quality of our services. It's cost saving. In this environment where economic is an issue, we always want to make sure that we deliver the best outcomes with as little money as we can, enable transformation as well as helping us to stay ahead. And we talked about innovation. Lee came to talk about our plans for the innovation hub. Again, that's the idea. The idea is to drive the culture of innovation wherever we work. So the physio team decided that this is something that they want to do. All the information, all the things that I've said about innovation, driving patient care, delivering a culture is what this project delivered. So in brief, they became aware that they had a long waiting list. Patients were not being seen and they were not very happy about it and they wanted to do something about it. So you can see that, just keep your eye on the waiting time that they had before and the total number of patients who were on their waiting list. They realized that there were staff challenges, long-term vacancies were a challenge, which again, there's demand and capacity is an issue. And there was also a shortfall. So again, it's all about sometimes when we are in our workplace, we would make all the comments about how we are busy, how it's too much for us, why we don't have enough staff. But in spite of all that, they decided that they want to do something about it. So we like people to normally register, and we can have a charter. You don't have to read a charter, but this is something, it's a one page which we normally give to our staff to be able to complete. We don't want them to complete reams and reams of information before they could do a QI, but something to show that this is what we want to do. And this is how we want to measure the success. So at least we can then have it in our record for future. If somebody else wants to do the project, then we can give them the ability to do it. So shout out to Anne and Katie. So like I said, the main intention was to reduce patient waiting time, reduce number of patients who are waiting for community physio, reduce the use of clinical time for admin. So I've been in the NHS for a while, and every time the money is tight, the first thing that happens is that people want to reduce the admin time. And then the clinicians spend their time doing the admin. And sometimes you have an effective admin who does all the work. So I remember working in the community, I would see so many patients. The admin supporting me would type the letters very quickly, and it became a machine, and we were seeing patients. And then the first time there's a savings, the admin goes, and then you find yourself seeing less and less patients. In this case, they put in some admin to support them. And as we've been celebrating, the ideas came from the staff and the patients that they were working with, which is crucial in what we want to do. So this is some of the things that they did. And we have talked about a model for improvement, and this is the principle which we want people to use as much as possible. I know people are busy clinicians trying to work and trying to do quality improvement. But if we follow these cycles, then normally helps to clearly identify a methodology to use for QI, which means that, you know, the way the arrow is going means that your colleague could come back and then continue, and then becomes a continuous improvement, and we keep going up and up and up. So these are some of the benefits that they achieved. So if you kept your remember how many waiting lists, the people they have on their waiting list. And when they apply their contact information sharing, this is where they got to. I'm actually interested in that one. This is the graph that I'm interested in. So this is where they started from, almost 600 patients waiting. And putting a methodology, clearly making sure that they have a waiting list management, phoning the patients, giving them feedback. The patient on their waiting list just keep dropping. And I suspect that this is at May 2024. I am hoping that if we go back to them, if this methodology is being repeated, hopefully we'll have a cycle which things are going down more and more. Again, time on the wait list before partial booking. So before they apply the principle, again, you could see an improvement going through. And the pie charts almost demonstrate some of the. So what then happened is that because they applied that, they were able to give call to your patients, develop leaflet to support patients. What then happened is that they actually spend more time, quality time, seeing patients. So they improved the waiting list, gave leaflets, and spoke to people who said, actually, that if you gave me some information to be able to help my back pain, then it means I don't have to come and see you. And then I'll come back if I need help. And the ones who really, really need help, they spend more time seeing them. So this is showing the number of contacts. Okay. The main thing is that the feedback from the staff. So instead of they complaining about we don't have enough staff. In the end, when they did a quality improvement to improve the efficiency, this is what they wrote themselves. And then important things about QR is that when you do it and it's showing improvement, please don't keep it to yourself. The clinicians in the room, the system has been rolled out to Whitby. So again, so it's do the improvement, apply the methodology, and when it works, spread. So embed it in your system and then spread it. Thank you for doing that, VCU in Scarborough. So the next one, which I was very close to, was on VTE, which is an assessment to make sure that when people go into hospital, because most people are more active than being in hospital, there's a potential for you to have blood clots when you're in hospital. And therefore, what we normally do is that we do an initial assessment as quickly as possible. And if you have the potential and the risk factors, we would then find strategies to help you so that you don't develop VTE and come out of hospital worse than you went into hospital. So the young doctors realized that the compliance rate, normal NHS target is 90%. That we need to achieve. We were not achieving that, and some patients were not getting their VTE assessment. So they set out this project to make sure that they achieve the standard which is needed. So again, we gave them our charter for them to complete, and we supported them with things to do. So initially, when they looked at it, they looked at 45 admission as a start and realized that they were achieving targets around 69%. And 30% of patients were not getting the assessment. So potentially the patients could be being at risk. So they did a few things. They raised awareness within the junior doctors group. Junior doctors have a toolbox which we put things on. We put posters in the clinic rooms. And then the other thing that we did was that we changed the sheets that they have, the forms that they have to fill, and added the VTE on top of that. So technology as well as old-fashioned information sharing. And again, they apply the same principle: plan, do, study, and act. So this is one of the things that they did. It's just a simple process, poster in the clinic rooms where the junior doctors normally talk to the patient from the start. So think thrombosis, think VT risk assessment, assess, prevent, and protect. So these are some of the things. So by the time they started the project in April 2022, the figures were hovering around 57 at 14 hours, 76 completed, and they took it all the way to within the 14 hours, 83, and achieved 93% completion, which is beyond the target. I'm trying to get a couple of the junior doctors to repeat it and see whether those information are still, so the cycle, continue with the cycle. So what the zero event means is that when somebody comes into hospital and we made it a zero event, i.e. to focus on it to make sure that it doesn't happen. So almost everybody should have a VTE unless it is completely not applicable to the person. So again, so I picked up on community services, one that was done by a couple of junior doctors supported by managers, and I also talked about the skill spread and embed. How am I doing for time? Am I nearly there? Am I doing for time? Oh, it's my timekeeper. 2 minutes. So this is a work that we've done with Imperial College. And I'm sure people have been to places where you go and there's something in front where you have to press whether it's sadness or you're happy. And normally, although it's important that you are satisfied, it's not actually very helpful. We know that 90% are satisfied with our service, but what does it mean? But this project actually look at areas, access to care, respect for patient-centered care. So all the ingredients, and then ask people to rate their experience. And what it did is using technology captured the feedback from the patient. So we were able, with that, we were able to create almost like a heat map of the real-time feedback from the patient. And then with that, we created what we called You Said We Did. So these are some of the things that the patients and carers were telling us, and this is the things that we did. This is something that hopefully once the project is completed, we'd like to have the technology to spread it across all our services. So instead of you clicking to say you are satisfied, you actually give us a feedback which says that. And this is making a change. So again, these are some of the things that the patient said. And you'd be surprised, people are talking about car park, and that's some very, very important for them, a reception space. So therapeutic areas. And these are very important things to patients. That's what they are saying. So instead of just saying, I'm satisfied with primary care, this is clearly what they are saying. So in conclusion, what I'm saying is that quality improvement works best when we do it with patients. So the patient tells us what is happening, we develop strategies around it, we co-produce with them. And a lot of work done. Some of this work doesn't look as a groundbreaking, big innovation, but it's helping so many patients. The VTE, in Avondale, we have 500 patients who are admitted, and it helps so many people. Obviously, finish with my last quote again. 2 jobs. You do your work and you improve upon your work. Thank you very much. Is there any question that anybody wants to ask?
Kwame, you going back to the physio in Scarborough, you said that about 39% of patients didn't respond to a letter. And then you said that there's a reduction of 28 patients on the waiting list each month. How much of that reduction is as a result of people not replying and being kicked off the waiting list, as distinct from a reduction in the actual number of patients being taken off the waiting list because they've been seen?
So the data was based on the people who responded in terms of the reduction. Is there anybody here who wants to contribute to that? So this was not an attempt to keep people off the waiting list. This was the people who responded. They had all sorts of ideas around, you still want to see us, and some people have been referred. They've sat in the waiting list for a number of months. Their situation has improved. I broke my leg. I was struggling to get a physio. I sat in the waiting list. So thank you very much. I'm happy. Give me some information. I'll use the information to support myself. Yes, I still need to see you. And then those patients would be called in to either seen as a one-off, twice, 3 times to improve. So as far as I could see, remember it in the patient who the reduction was based on those who have responded and something they did about them. Anything from online? Thank you very much. Continue to do the quality improvements.
Thanks, Kwame. So please can I ask, welcome to the front, the Children's and Learning Disabilities Division presenters for the Connect website.
So hello everybody, my name's Danny, I'm one of the engagement leads for the Adult Learning Disability Service.
And yeah, I'm Flick, I'm the engagement assistant for Children's Services, so you've got me twice, you're very lucky.
We're here to tell you about our quality improvement, the Connect website. This is our divisional website for the Children's Services and Adult Learning Disability Services.
So the website was funded by our wonderful digital team, and we worked for around 14 months with our 28 children's teams and 5 adult learning disability teams to create Connect. So the website is designed to have accessible information in a single point of access for children, young people, adults with learning disabilities and those who care for them. So we launched the website in October 2024, and since that launch we have on average 400 to 600 clicks on the weekdays, and on a weekend that goes up to 1,000 views. So already since its launch we're having a really good footfall on there, so we're really proud of that. Hopefully I'm going to play you a video now which will just introduce you to Connect. Do I click again? Is that correct? Yes.
Hi there and welcome to our Connect website.
We're a group of young people
And adults
from all over Hull and the East Riding of Yorkshire who have all used the services at Humber Teaching NHS Foundation Trust.
Their teams work in loads of different places to support people like you and us with our physical and mental health.
They work in schools, day services, community settings, health centres, inpatient units, as well as in people's homes.
This website brings all these services into one place so you can find the information and help you and your family need.
Because sometimes we know it can be hard to reach out for help.
And to find the right support for you.
We want to tell you that the people at Humber Teaching NHS Foundation Trust care about you. They are friendly, approachable, and they want to help you. Make sure you check out our Help Hub if you need support but don't know where to look.
Or our resource hub for all sorts of useful links and information.
Thanks, and we really hope that things go well for you.
Bye, see you later.
So I'm just going to tell you about a few of the features on the website. So we have easy read documents on the pages created by our speech and language therapy team. These are documents that have simple language and sentences alongside easy read symbols to help with understanding. We have the Reach Deck, which is an accessibility tool that will help people navigate around the website. It has different features depending on what your need is. So some of them are magnifying the text. It can read information out loud, whether that's a sentence or a paragraph or the whole page, and it can translate information into the language that is suitable for you. We have the Help Hub, which is currently still in development and hopefully going live soon. It's basically a tool for if you're visiting the website for the first time and you might know what support you need, but you're not sure what team offers that. So it'll ask a couple of questions and then you write your keyword in and it should narrow down that search a little bit. We have over 1,000 resources available to our visitors to read and download. And we're going to animations and I'll walk through video tours which have been co-produced with our young people and adults with a learning disability during the rest of the presentation.
So our service users were absolutely essential in ensuring that the website was highly accessible, engaging and resonated with our diverse community. So we are proud to involve service users throughout the whole of the project, and without them, the website wouldn't be as half as good as it is now, really. And we're really proud that our website was awarded the co-production stamp as well, to really highlight that co-production.
So we're just going to give you a bit of a snapshot and highlight how we've co-produced with our adults with a learning disability throughout the project. They've been involved from the beginning. So we have had, we work closely with a group of volunteers, a group from Same Difference Day Service and a group from Redwood Glade Supported Living, and they created the cartoons, the characters for the animations. We invited patients to Town End Court to have their photograph taken alongside staff members, and JJ Media also went to Granville Court, our residential home, to capture one of the activity sessions with our profoundly disabled clients. I met with some of our patients on a one-to-one to understand about their lived experience and what their thoughts were on accessing our services, and that information helped us create our website scripts and our posters.
So I just want to highlight a few ways that we co-produce with the young people as well. So we had one expert by experience who supported with the interviews, and they were essential in choosing the website designer, which was Infuse Media. And two experts by experience were employed throughout the whole project, who were equal decision makers with us. 70 young people from local schools, youth groups were involved in the planning and the development of the website, and 19 young people from the Humber Youth Action Group supported with virtual tours and animations. And the experts by experience also spoke at the launch and stakeholder events, highlighting the real importance of co-production.
We can't forget our staff members. So first, we would like to thank Bethia Dennis and Steve Jolly, who had the passion and drive to create the website, and they submitted the initial bid and secured the funding. A big thank you to Dan Webstale, our project manager officer, who supported us throughout. We had regular strategic meetings with a range of different professionals who gave us advice. Gave us advice and ensured our website met the trust standards. Most importantly, thank you to the clinicians that are very busy with their complex caseloads to give up a little bit of time to become a website representative. We had 2 to 3 from each team that would come to our regular meetings and feedback to the other members, but most importantly, get the content that we needed for the website and made sure it was at the right level for our adults with a learning disability and our young people.
So one thing we feel incredibly proud of is we feel Peter, the animator from My Pockets, who animated the young people and adults, we really felt that he captured the people and he made them an individual. These aren't AI generated people, these are real people. So just to highlight the wonderful Poppy, if it works, there she is. So this is Poppy, she's a young person and she's part of the Humber Youth Action Group. And when she sent a picture of herself to me, she said, please can you make sure I have got big eyelashes on my character? And I really do feel like Peter did achieve that. And then we've got Tristan, and he attends Same Difference, which is a day centre, and he's an adult. Now Tristan, he wears his t-shirts in alliance with the weather. So obviously on this day it was cloudy because we live in the UK. But you know, I know people who don't know these people wouldn't know that, but they really make these people, the true people, the real life people, and we really are so proud of that.
So Peter, our animator, spent a lot of time with each patient to get to know them better. He learnt about their personality, interest and hobbies to help bring the cartoons to life. So I'd just like to introduce you to Deborah. She's a young person and a Humber Youth Action Group member. She's currently studying to become a dental nurse, which is her dream job. So she always has her backpack because she's always studying really hard. And when she's not studying, she's in the kitchen making new recipes and enjoying some cooking and some downtime. Oh, sorry. This is Jack. He's one of our adults with a learning disability. He has a real passion for music. So this is his bedroom, and he has his record collection. He enjoys listening to music with his mum on the weekends. He has a keyboard because he's in a band. He plays the keyboard and does live shows. And then just the extra nugget really is that he has an obsession and collection for a collection for keys, which is why it's in the frame on the top. But if you didn't know Jack, you wouldn't know that. But we've got one of the videos to show you it in action, which feature Sophie and Alan, and it's Town and Court Inpatient Unit.
Hi there, we're a group of adults with a learning disability who have access to Town and Court at Humber Teaching NHS Foundation Trust.
We're here to talk to you about Town End Court.
This is an inpatient unit. There is 2 units called Willow and Lilac, so that's us.
They support people over the age of 18 with a learning disability, autism and mental health diagnosis, and or challenging behaviour.
They can provide a safe space for care and treatment for people who have become unwell and need to come into hospital for extra help.
You might be feeling angry, anxious or alone. You might be struggling to keep yourself safe.
They are here to be part of your journey to recovery, to help things get better.
There is a group of people who are specially trained in different ways to support your needs. This includes nurses, psychologists, occupational therapists, speech and language therapists, and lots of other people too.
The psychiatrist will oversee your care and meet you in weekly review meetings.
They offer assessment and treatment which cannot be safely provided in the community.
They can help when you need more support with your mental health, behaviour and emotions.
They offer therapy to help you return back home.
There are 5 ways they may do this.
Creating personal care plans based on your support needs.
Working with staff teams to make sure the right environment and support is in place for them to care for you.
Creating positive behaviour support plans for when life is hard and you need extra support, like we all do.
Take part in activities that are important to you.
To develop communication skills, to learn to express emotions rather than behaviours, so you can be happy.
And loads of other stuff too.
An admission to hospital is a last resort or an urgent response. It is not a planned or a frequent event.
On most occasions, you would be known by the intensive support team.
If you need help from Town and Court professionals who know you well, will get in touch.
With their support, hopefully you will begin to overcome challenges and worries in your life, to feel happier and calm and better all round.
Like we all deserve to.
Cheers, mate.
Bye.
Good luck.
So one thing we were really determined to achieve was for the website branding materials to align with the website and animations themselves. So these are examples of the posters that we've got that promote the website. And I really feel like these posters achieve this. So these are the direct words from the children's and adults who accessed our services. So Peter came to the Humber Youth Action Group and he asked the young people how they felt at the start before they accessed our services. So for example, they felt stuck in the hole, they're in the tunnel and they needed, a torch to help them find the light and to come out the hole, to dig themselves out that hole. And adults shared that they always felt that services were always here to listen to them when they needed us. So we really wanted to capture those words of the adults and young people on these posters. So we're really pleased with that as well.
As well as the animations, we also have building tours of each of the NHS sites. So JJ Media helped capture these. So as well as the building tours, we have photography, which we're hoping will be put on appointment letters to try and support people. We aim to put as much detail as we could. So we, as well as like the therapy rooms, the receptions, we also added them extra bits of like the front entrance from the street and parking. We just want to prepare people as much as we can to visit their appointments if it's the first time, to relieve any anxiety. And then I've just got a little story from Janet, who was in the video, the lady with the purple hair. She can't come today, unfortunately, but she's agreed that I could share her story. So Janet's an adult with a learning disability. She's 70 years old. She has always struggled with her reading and writing. She missed a lot of school when she was younger because she has epilepsy. It's always been something she really wanted to learn, so she found a company in Hull, and the last couple of years she's been learning to read and write. When me and Flick met her on the day of recording for the films, she had a certificate with her. She was proudly showing it off, of such an amazing achievement. And we feel really honoured that we was able to give her this opportunity, because she read her website script for the building tour independently, and she was so proud, and we were proud of her. And we'd just like to show you one of the building tours, which is the East Riding Community Hospital.
Welcome to East Riding Community Hospital on Swinemore Lane in Beverley. My name is Jess, and I'm going to tell you a few things you may want to know if you are visiting this building. The hospital has its own bus stop. Or if you're arriving by car, there's plenty of free parking. Use the left-hand entrance to the hospital. The right-hand side is for urgent treatment centre only. The building is used by a number of services. Once inside, there's a reception and a spacious waiting area. One of the porters will be happy to show you the right way to your appointment. There's an accessible toilet and changing place available. There's also a welcoming waiting area for children and young people attending appointments with occupational and physiotherapy therapy. Here are some examples of spaces within the building. Thanks for watching.
Now we would like to invite up Sophie and Alan, who you might recognise from the video. I'm going to do a short speech each that they also did on our launch event. So Alan, would you like to come up first?
Hello, my name is Alan. I live at Redwood Glades, which is an independent living home in Hull. I volunteer in the kitchen 3 times a week and do the bingo twice a week. I have experience of public speaking. I was asked to do a speech at London event in London. I'm a proud great uncle. It was great to be part of the video. I think it is important there is a video on the website in case people aren't able to read. This will help them understand the information easy. I'm proud to represent people with learning disabilities on the website. Thank you for listening. I will now pass you over to Sophie.
Hello, my name is Sophie. In my spare time, I enjoy creating diamond art and arranging fundraising activities to help others. I have previously performed in a flash mob using Makaton signs to the song This Is Me at a learning disability event in Hull. I would like to say thank you to the NHS for letting us be a part of the project. It was easy to work with Peter when creating the videos. He made the session fun. I think the building tours will help people plan for their health appointments in case they are nervous. Me and Ellen was also invited to do a speech at the launch event, which we enjoyed. It was a good experience to help build my confidence. It will also help prepare me for future if I get more opportunities. Thank you for listening.
Thank you. Any questions? Thank you.
Thank you.
I think we might have got away with it.
No one has got a question.
You've got away with it, Alan. Come on, quick.
Thank you. It is break time. We are running a few minutes behind, so can we ask everyone to be back at 3:15? If you have any flowers or part of the special recognition, can you just wait so we can get some photographs, if that's all right? Thank you. Break time through there. I'd like to welcome our Primary Care, Addictions and Community Services Division to their presentations.
Good afternoon all, and for those online, I hope you're enjoying the day today. My name's Phil Anastasia, and I'm the Primary Care, Addictions and Community Services Patient and Care Experience Lead. And I'm going to showcase for you today, with the support of these lovely ladies here, about some of the projects that we've worked on in co-production and worked on with patients within our division. First of all, we're going to look at the primary care division, and I'll introduce Laura shortly. Our first showcase project was the practice web design project. So this basically, to set the scene, came about because practice managers of our 3 GP practices, which is King Street Medical Centre, Humber Primary Care and Market Wheaton practice, noticed a number of patients were finding it quite difficult to navigate our current websites. And this also involved finding information on there quickly with the least amount of clicks. So based on navigating and based on intelligence that we received from GP annual survey results, monthly friends and family results, and friends and family test responses, this really highlighted some of those issues. And as a result, the team decided that we would develop a quality improvement project designed to gain feedback from the wider patient audience when communicating with the practice through the website. And this included looking at its design and layout, its functionality, its content information, its ease of use, and improvement recommendations. So the start of the process was we started to develop a questionnaire. This questionnaire was based on 7 key questions that was going to be sent out in a survey through the AccuRx system that the GPs run for anyone who's registered with a mobile phone on the GP practices. And this would be sent out to anyone aged 18 plus to get involved and make their comments on the current website. The key questions we asked were, how often do you visit the practice website? How satisfied are you with the design of the current practice website? How would you rate the ease of navigation of the current website? When using the website, were you able to find what you were looking for? And when you use the practice website overall, do you find the practice website content relevant? And finally, how would you rate the ease of access of your practice website features when you're using it on a mobile phone? So we were trying to kind of understand inclusivity. The key feedback summaries from that first survey was that people said the functionality overall on the website, whether it was on the mobile device or on the desktop, was poor. It was visually confusing. It felt it would be better to make the layout like the national NHS app and national websites, so that you had that consistency of look and feel of the navigation in general. They wanted the sites easier to navigate with less clicks. They wanted clearer navigation bars and headings, and clearer information on how to book an appointment, which is a key part of the total triage system using AccuRx to do an online consultation to generate and request an appointment with your GP practice. They also felt that the direct links weren't that clear to getting test results, ordering repeat prescriptions. So we had quite a lot to go at. Step 2 was following the evaluation and some of those key points that we looked at there, we developed and established a bit of a steering group. This consisted of 3 practice managers, 1 from each practice, myself as patient engagement lead, and a patient representative from each practice that would help us to evaluate the information, start looking at what the design might look like if we were to change it, what that functionality might look like as well. And we also had a lot of support from the comms team that are sat over there. Once agreement had been made, we then moved into step 3 of the process, where we involved all our practice individual volunteers, and they engaged with tablets with copies of the old website, copies of the new website, and we gave the final choice to the patient whether they stuck with the original website, which was obviously unlikely based on the feedback we'd already received, but whether they actually liked the new concept with all its new features, in order to roll that out and make any slight tweaks before we went live. We were really pleased to report from the volunteers that 77% of all the people that we engaged with face-to-face across all 3 practices all liked the new concept, and that really gave us the green light to get comms to push the button on it. So we launched, and we relaunched this in May 2024 for all 3 practices. And Laura has kindly offered some of her time this afternoon. So I'm going to hand you over to Laura, who is the practice manager for King Street, to give her perspective on the impact that the practice website redesign has had since it relaunched in May 2024.
Thank you for that, sir. Much appreciated. So yeah, I'm the practice manager of the King Street Medical Centre in Cottingham. And like I say, from a practice manager's perspective, it's really important that we engage with our patient demographic and listen to their voice, because as people have said today, it's really important to actively listen, gain that quality feedback and actually make some progress in improving our services and making an experience better for them. So I think we all know very well from things that are going on in the media and the government and elsewhere that access to GP services is a hot topic. So one of the things that we're really proud to do is make sure that when people are feeling unwell and they need support, whether that's, in the middle of the night or, first thing in the morning, they've got that ability to go onto the website and access the necessary information and get in touch with us in any way they need to. I think what's really important from what Phil was also saying is in regards to the accessibility on the mobile devices, because we obviously figured out from the feedback we were getting, we're not using kind of PCs and other devices anymore. It's all on your mobile phone, and it needs to be friendly, it needs to be quick, and it needs to be responsive to the patient's needs. I think the most important thing for me is making sure that something's familiar as well. So from a patient's perspective, a lot of the themes that they see on all the other websites and designs has the same kind of colour, the layout. It's all friendly and familiar, because when you're feeling unwell, the last thing you need is something complex and difficult when you're trying to navigate your way through there. What's really something we're really pleased about is the amount of responses that we get as well. So in terms of the friends and family feedback that the PACE team and everybody else support us with, in primary care across our 3 practices, we average about 1,300 pieces of feedback a month based on all of our patient contacts. So the information that we get is really detailed, it's really valuable, and it's really nice as well to read some positive feedback as well from the patients and their experiences. The other thing in terms of kind of digital inclusion and considering patients' experiences is this is all about choice. So I think from a patient's perspective, it's really difficult in a digital climate for people to expect to use these opportunities on the website if they're not able to. So it's making sure that we're inclusive and that we also engage patients to pick the option that's most suitable for them. Because I think it's very fair to say that some of the reports that we get about GP practices is you have to. And I just wanted to kind of take an opportunity at the podium today to say that's not the case. We're open, we're accessible, and we like to give patients the options that's suitable for them, whether that's on the telephone, whether that's in person, or whether that's through these online tools that we use. Looking at the figures and all the information that we've had following all the kind of audits that we've done after this, we've had an increase in positive patient feedback. So I'm really pleased to say that all 3 of our GP practices are above 90% on their SFTs for January. So it's really, really positive. and the increased figures for the website usage. So the online tool that we use for collecting the data for our online consultations has shown that we have at least 60% of our patient demographic using our websites now. That also couples with about 10% of patients using the NHS app, which also obviously links into the patient knows best and the hospital systems. So it's really nice to see that the changes that we've made have had a really positive impact in the way that patients are accessing their care with us. I'd like to make a special thanks as well, really, to Phil, the PACE team and everybody who's been helping us, and to everybody in volunteers as well, because without their support, I don't think this would have been possible in the way we would like it to be. And in all of our GP practices, we've got kind of a massive team of volunteers now that are engaging with all the different projects we're taking part in, and simple things like supporting us with vaccination programmes and getting patient feedback here and then in the practice with tablets and various other tools. And it's also speeding up their access, which is the main aim of the game. So yeah, lots of people have given us positive feedback in terms of getting access to prescriptions, completing online consultations, and the online consultation tool gets positive feedback as well in terms of giving that patient an opportunity to capture all their thoughts. Because I think historically it's really difficult to be shoved into a 10-minute appointment with someone and try and give them all of your thoughts and feelings in one opportunity. So the fact that we've been able to link those two things together, I think, has really improved patients' experience and their access to their appointments. That's me done. Thank you.
Okay. So our second showcase comes from our East Riding Partnership Addiction Service. So I'd like to welcome Jess Murphy, who's going to talk about a case study for a project that we supported her with.
Thanks, Phil. Hi everybody, so I'm Jess Murphy, East Riding Partnership Service Manager. And when we look at Buvidal depot injection, I just want to make sure that everybody knows it's an opiate substitution therapy, so it's designed for the treatment and management of opiate dependence. So for some time, East Riding Partnership had, I've lost my train of thought. East Riding Partnership Services, had for some time monitored national interest in Buvidal 28-day opiate substitution treatment. For those of us that believed in the product, staff and patients, we wanted to continue to influence others with the main aim of having this treatment more readily available to our patient group. Following discussions with our service providers and commissioners, they agreed to fund a pilot for 5 patients deemed suitable for the OST treatment. The commissioners, alongside the service users, wanted to capture evidence to measure the differences between traditional opiate substitution therapies and the new product Buvidal depot injection. Everyone was keen to understand the both positive and negative experiences to gain a sense of quality of life improvement and hidden gain alongside the clinical treatment. As a result, the commissioners agreed to embark on a quality improvement project with the pilot patients who also wanted to raise awareness of the treatment to promote the positive and negative benefits and to increase any myths, to dispel any myths. In June 2023, we introduced the monthly injectable form of buprenorphine. We introduced injectable buprenorphine because traditional opiate substitution treatment often required daily supervision at a chemist, which was obviously problematic for our patient group and often posed various challenges. One of the most challenges that people reported was the continued stigma and embarrassment of attending the chemist every day, having that supervised and dosed and being watched. Also, the employment barriers arose due to the time constraints of the pharmacy visits. This would often impede people's employment availability. We have a small cohort of fishermen that would work offshore that couldn't commit to daily supervised consumption. And also the mental health strain that this caused. Regular medication meant constant focus on timing, focus on doses, which was psychologically challenging. Patients' initial feedback became so overwhelmingly positive that the service felt compelled to promote its success by capturing the patient's voice. The benefits of buprenorphine injection is the monthly administration, so alongside OST, it can be prescribed weekly initially until they're on a stable dose, and then it can be given monthly. So obviously people haven't had to go to the chemist every day to have the medications to be watched. It gives individuals flexibility, increases stability, and those that are more chaotic that we couldn't retain in treatment because they had to attend chemist daily, it's had a positive impact on them. It also improves patient safety because it's more controlled. 100% of the medication, access to systemic circulation, there's no peaks and troughs, and there's no risk for diversion. So it's important as a service and for the service users to evaluate the success of this challenge and the broader impacts on recovery and quality of life. We collected data by collecting a patient survey approach. The target group was 25 individuals that were prescribed buprenorphine prolonged injection for a period of 10 months before completing the survey. We collaborated with peer mentors to co-produce the survey and produce the questions through our Voices forum, which ensured that the survey truly reflected our patient group, language and concerns of the patients. The questions were designed to capture both positive and negative impacts and focused on recovery journey, employment opportunities, social and family dynamics and health improvements. It was hoped that if the patient's experience was positive, the service may gain further funding to offer this treatment to a wider audience. So obviously there's a bit of the feedback. I'll leave that on the screen while I just go over the data that we collected. So most of the data that we collected was obviously qualitative. It was detailed patient feedback from patients about their recovery, mental health and employment. Key areas explored was the daily impact on routine, the no need to attend the chemist daily and the stigma, and the employment benefits due to pharmacy attendance. It obviously had cost implications. People will obviously have to access the chemist daily. This would mean bus fares, taxes, which obviously some of our population don't have access to. Obviously, if people are stable in treatment, it reduces crime and has a further public health benefit. You've got the clicker. I'm sorry. You're all right. So if I just briefly summarise the outcomes and the key themes that we learned, is that the overwhelming positive impact of patients prescribed injectable buprenorphine was so overwhelmingly positive. If we look at the freedom and flexibility, 92% of our patients that completed the survey reported a positive impact on their lives, no longer changed daily pharmacy visits, routines, and patients prescribed buprenorphine described feeling normal and was able to regain control over their schedules. It also had great impact on employment outcomes. 53% of individuals stated that they had put their employment at risk. With injectable buprenorphine, patients found it easier to maintain steady employment. Again, with the fishing population, they was obviously able to go out at sea for some time, meaning they didn't have to return for daily dosing. If we look at individuals' health and well-being, 69% of patients noted health benefits, improved physical activity, attending the gym more, better sleep, better mental health, and more energy. Also had significant impacts on the wider family and social impacts. 92% of patients stated their family and support networks experienced positive impact. People have reported less worry about carrying medications, as traditional OST would be large quantities of tablets and liquids. They felt no longer stigmatised and had freedom to engage in family life. Many patients reported feeling more trusted and emotionally available for their family. As with anything, we did pose some challenges and room for improvements. Some patients did experience side effects, such as mood swings and discomfort at the injection site. The weekly injection does contain alcohol, so it can be a little bit stingy. A small cohort requested evening appointments to better fit around their work schedule, which was soon implemented, and we hold regular late night clinics for our working population. If we think about next steps and recommendations, it would be nice to explore the administration model in the community setting to further increase accessibility, meaning that pharmacists may be able to administer this medication rather than nursing staff. We'd like to continue to promote the injectable buprenorphine as an effective treatment outcome, ensuring it reaches more people who may benefit. The introduction to injectable buprenorphine has had a transformational effect on patients' lives in significantly improving patient recovery, mental health, family relationships and employment. By collecting patient feedback, this has been invaluable in understanding the true benefits of this new treatment and identifying areas for further improvement in service delivery. We hope in the future that we can put the patient's experience captured within this pilot survey to be developed into posters and leaflets, which may encourage further patients to consider the benefits of buprenorphine. Also, it's provided a business case for whole primary care to offer Buvidal treatment as a small cohort of patients, which again is also increasing accessibility. That is me done. Any questions? Didn't really wrap that up well. Oh.
Hiya. How do you, is it too early to look at how you reduce dependency or dosage through the injections on those taking them as a substitute?
So on Buvidal, it's not licensed for a detox or reduction. There is a few ways that people can reduce off the medication, and it's patient-centred. It's discussed with those. We can transfer to sublingual, back to methadone, but at the moment Buvidal is not licensed to reduce off, unfortunately. We have had patients that have decided just to stop taking the injection I can only speak from my hub in Bridlington. In the 4 people that have reduced, only 1 has returned back to OST.
Thank you.
Brill. Thank you.
Okay, so our final showcase case study is from our physiotherapy team. So I'd like to welcome to the stage Annabelle Armitage, who's going to talk about our first contact model.
Hello. This is a little project we did sort of last year, or finished it off last year. During the pandemic, we could only speak to people on the phone because obviously we couldn't see them. And so we, for nearly a year, did do most of our MSK work through the telephone. Just to explain, our service runs Whitby, Scarborough, Pocklington and Malton, so we're quite a large area. We managed the patients on the phone, and a lot of the patients were quite happy with this model. So, but we got a little bit of feedback from some of the GPs on the referrals. This patient must be seen face to face, and the FCPs, who are the sort of physios who assess out of the GP practices. And although when we asked patients if they were happy with the model, the majority of them seemed to be. We thought we need to actually be able to listen to the patient, see what they're saying, and check that this model is meeting everybody's needs. So we then embarked on a QI project to get some feedback from the patients. So we these are the questions that we asked. I wanted the age because I was just quite interested to see what age group we had, and to make sure we got an equal section from each of the 4 areas that we work out of. And I wanted to see what their thoughts were before they got the phone consultation, because quite often when you ring a patient up and you say, we're going to do this by phone, they went, how can we do physio over the phone? When they've actually been listened to for half an hour and you've done a full subjective history and worked out and discussed a plan with them, they're often understand what we're doing. So that's why we put that question in as well, number 4. And the other thing, the main reason for the telephone model wanted to use it is it was helping us tremendously to manage our waiting list. So the results. So I wanted to get a good sample size. So we got 200 and ended up with 201 patients till we sort of reached a bit of thematic saturation. So we stopped it at that point. The average age, or the majority age, was between 51 to 70, so that was useful to know that we have that sort of is our main population. But what was the sort of interesting bits were the figures here and over there as well. So initially there was, I'm not that good on the percentages and I haven't written them down, but there were 117 patients who thought it would address their needs. But when we then went back to them afterwards, it was works out up over 90%, nearly agreed or strongly agreed. So actually they were happy after that initial consultation. And then we also asked a question about, would you rather wait less time and have a telephone consultation, or would you rather wait longer? And again, that swung in favour of the telephone consultation initially, and have a shorter waiting time. We then just got some feedback as well. Phil compiled this rather useful thing of just what people felt was what they wanted. And again, it was good. It was the overall experience, or the good telephone experience, and a good telephone follow-up. And that's the important thing, is that we do stress to patients that they will be seen face-to-face. The telephone call is like a triage call to work out where we're going to put that care. So, and we now, well, this comes in the follow-up act, but we now document in every patient record, patient has agreed to face-to-face, or patient happy with a telephone follow-up, or patient happy with patient-initiated follow-up, depending what they want. But this is the next bit. So these are sort of things that we did. I think we needed. I think it was important from when the patient rings up, or even when they book the appointment on our website, that they understand about the telephone model. So we spent a bit of time trying to, when we do our opt-in letter, which I think they talked about in the community model, we do a similar thing. We explain in that your initial phone call will be, your initial contact will be telephone. This will be followed up potentially by face-to-face or whatever. And we've also done, we redid our leaflets, and I've got them spread out in a lot of places. So we put them in the urgent treatment centres, in GP waiting areas, around the different hospitals, so that we can get better access as well, so people know more about it. And we've done some posters as well. And we've done a few of these presentations just to explain what our model is, so that the people who are referring in understand what we do. And I've spent time in orthopaedics understanding to them that what we do. And I think it is becoming now more of a a sort of consistent thing. And actually, I think the more patients are and referrers seem happier with the system now. So that was good. So we learned quite a lot from it. So I think that's it. If anybody's got any questions. No. Thank you very much.
No, I'm just going to make a comment. Comment about the website, NHS website, and I've heard people saying that everybody is going down the website route, and the alternatives are not there. But from what you are saying clearly, there is still, people can still turn up in the surgery. They can still use the phone, and they can still use the website. And for me, I think that giving people those choices are clearly very, very important. For me, my preference is to use the app to book an appointment rather than be patient number 7. You are waiting in line. And I think that the positive thing about the website is that it actually means that instead of people being patient number 8, means some of us are using the website so they can be patient number 2 or number 1. So people should see it in that way. I think the beauty where we want to get to is also to make sure that we don't continue to reduce the service of the phone, or people being able to turn up like what the banks have done, to say everything is gone online, and then one day you need to go to the bank for something that actually needs to be there, and it's gone. So hopefully we need to guide against that. So that's all the reflection I want to make. So thank you for sharing your story, your projects. Well done.
I'll come to you, don't worry.
It was just a question for the King Street GP, really. Do you find that because areas such as Cottingham have a more, to put it politely, an ageing population, do you find that a lot of the website issues surround that, and has that had an effect on keeping telephone lines, walk-ins available? Because I know that a lot of places, especially in Hull, have switched now to you can really only get an appointment via websites.
When we have a look at the data and the friends and family and the feedback that comes on, like,
Sorry about that.
so that anybody could hear a single word I was saying then. Thank you for your question. In terms of the data and kind of where we were looking in terms of the age ranges and the demographic, I think you'd be really surprised, because I think you make an assumption that because, you know, Cottingham's quite an affluent area with people who come to retire because it's a lovely place to live, that actually the demographics of the patients, there's a lot of patients of older ages that are using all of these tools. We get quite a lot of feedback as well from our housebound population, because obviously for them, sitting at home on a queue and, you know, waiting for that kind of feedback from people, the new systems with the access on the website and the online tool, again, gives them that opportunity to sit when they're at home, get all of the necessary information in and kind of prepare themselves for that conversation with the clinician. So I think, yes, we do have to make sure that there's opportunities for everybody to go through more than one door, so website, face-to-face, and over the telephone. So our care navigators assist people for numbers of reasons, because when you're feeling unwell, the last thing you know, some people like to write forms, some people don't. So I think it's really important that we have an opportunity to give people those options and let them choose. And then that also gives us the capacity to be able to kind of look at the resources that are coming into the queues on the telephone, how many online consultations we have. We've become quite strategic, I think, in the teams that we're in, because we sit and we look at the workload for the whole day, and we kind of look at how many online consultations are left to be looked at, how many incoming calls do we have, what are the queues, and then kind of tailor the administrative support in the practice on a day-by-day basis. So that can peak and trough dependent on kind of the skills of the people we've got in the practice and then the needs of the patients on that any given day. So it's given us all the flexibility to kind of put the resources where we need them, because we know they're scarce, and we want to try and give people the benefits of what we can offer. Any other questions?
Thank you. I would like to say some primary care compliment of where I live, the primary care unit at Valley. They saved my life.
Oh, that's really lovely, thank you. And I do appreciate, we do work quite closely with the Humber team, the Humber Centre team in the primary care section, so it's really nice to hear that feedback from them. Is that everybody? Have I skipped? Thank you.
I'd like to welcome the Right Honourable Caroline Flint to the front to close the session.
Thanks very much for having me here this afternoon and being able to take part in this afternoon's event. I bumped into Lynn Parkinson on my way over, and she just had come away from the morning session and just said how wonderful it was. Is it actually all being recorded, the event? Brilliant. So I can catch up on everything that happened this morning. Fantastic. For it, that's brilliant to know as well, and to pass that on to others who can't be here today too. I mean, it's very interesting, that last section of discussion around, you know, trying to look at different ways to do things, to use technology. Earlier this week, the board which I chair, we actually had a special digital board session. Kwame was there as well, other executive directors, other non-executive directors. And it was partly developed out the fact that we'd, many of you who are here today who work at Humber, but also maybe some patients and others who may have been asked about this. And I noticed you had Mr. Lee Rickles on this morning, our IT digital supremo. But basically, we're moving to a new system for keeping electronic patient records. And certainly when I became chair for Humber just over 3 years ago, and when I went out on my visits around our various services, and particularly in talking to staff about, you know, what are the things that were the bane of their lives, one of the things was the difficulties they found using the old system we're moving away from, Lorenzo, because it's very clunky, but also it didn't capture some of the community information we might have about patients and service users alongside those who use our inpatient services. And so, you know, every time I went on a visit and this came up, and it came up literally every time, and I fed that back in, I was reassured to know that that had been captured and it was understood, and we wanted to move to a new system, and that system will for an organisation like ours that has a whole range of services under System 1, have one system that unites that community-based information with those of our inpatient units, and that's really important. And we've done a lot of thought about how we do this. And to all the units who have gone through this process, I think we're at the last stage. I think it was the Children's Young People's Division. We'll just come to that. We're really pleased about. But we wanted to think about beyond that as a board, about again how we could capture these new technologies, because they're pretty scary. I mean, honestly, it is a brave new world out there, and we've only scratched the surface. And I think we should all be honest. I'm on the NHS app. It's great, but it doesn't really join me to my GP's website or other things as well. So I'm thinking, why can't I do that? But I have to say, I've also been on the receiving end of trying to get a refund on a train ticket through LNER. And if anyone's tried that, it is a nightmare. And those chat box, I mean, you know, I like to think I'm quite a good person at words, but when it says, can you rewrite your question and use another word, and it just doesn't work. And I was at something actually just yesterday, and this is clearly not going to happen at Humber, where actually organisations in the private sectors, like the banks and everything, actively do everything to stop you speaking to a human being. It actually is part of their marketing and their corporate strategy. We're not going to do that. Aren't we? We're not going to do that at Humber. It's not happening at Humber. But we recognise that actually we can, you know, people can actually maybe use just, you know, a high-tech tool, hopefully, that is smooth for all their needs. But also, and I'm one of these people, I want to be able to sometimes do, you know, the old version, speaking to somebody, talking to someone, engaging with someone, but whilst using the benefits as best I can of those new means to communicate and get what I need. This afternoon, it's been really great being with you and actually just being reminded of some of the things I've been privileged to see firsthand in the last year. And I'm just so glad you got a chance to see the videos as part of the Connect project. There was only one of those I hadn't seen before, which was the first one introducing, but I'd seen the other ones when I was at the launch of the service. And I just think, and you heard Peter mention quite a lot, I think, from everybody. And I got a chance on that day to just have a cup of coffee with Peter, who was instrumental in working with everybody in devising the artwork and the animations. And I honestly can tell you from the heart, he really wanted to do justice. He didn't want to take, you know, just, you know, stereotyped images of some other graphic website or graphic library. He really wanted to have some authenticity, some, you know, real quality, but also so we could both see and hear people's voices. And I think he's done a tremendous job. And I don't know where it's happening, but I think we're going to be looking to promote what everybody has achieved, and I mean everybody has achieved in that project at another level to show what could be done. Because one of the really difficult things I've always found in my working life in different areas, I've had the privilege to see such good practice in different organisations, and sometimes we're not that good at sharing best practice. And the other side of me is I don't believe in reinventing the wheel as well. So I think I'm hoping that we might be in for some more recognition outside of the recognition we give to the quality of that service this afternoon. So pleased for Jean getting her award today. Jean was one of the first people I met actually when I came to Humber. I don't know whether I should feel bad about this, Jean, or to blame for it, but Jean came on as a governor when I first started, and then after a while we chatted and everything. And Jean is, as you know, a very busy person, and she said to me in a very nice way, just said, look, I enjoy it. I'm glad I became a governor, enjoy it, but I'm just doing all these other things and I can't do everything. And I recognise that, but my loss, if you like, or our loss was everybody else's incredible gain here as well, and continues to be. And that's what's great, isn't it, about being involved and being active in different things. You can, you know, you might change something what you're doing, or you might do something else, or some other opportunity come up. Marilyn, who was here, and she's just had to leave a little bit earlier this afternoon. She's been involved in the quality improvement work, really interested in the research. So you can find different things we can do. And they've got Tim and Anthony here, also governors who are involved in different ways as well. So, but well done to Jean, well done to Anthony. Anthony, I often see Anthony. Actually, he's you know that thing carpool karaoke with Peter Kay and what's the other one? No, well, actually not Peter Kay. Peter Kay had the program, didn't he, where he was in the car going to work all the time. I'm sure he could do it as well with James Corden. Well, often Anthony is out on the road when we have meetings online, and he's not driving, by the way, when this happens. He pulls over into a lay-by, and we see him on screen from there. So, but your recognition today is very. Really is important, and what you've done, and very deserving. And Ruby, I don't know if Ruby's still here, but Ruby came to actually a board meeting. I think it was a board meeting, or was it a council of governors meeting? But she shared her experience of being a meter and greeter at the practice, and the work she's been doing there to help make sure the patient's voice is heard in that community. So well done to everybody. To Gemma's been brilliant. I think Gemma might have had to leave now, but Gemma has actually been, where is she? Where is she, Gemma? There she is, hiding at the back. Gemma, really well done. You've been great to work with this past year as well, and the events you've helped to organise, the work you do on Health Stars, but the staff awards and everything, it's just been fantastic. And of course at the staff awards we also had a volunteer awards as well, recognised this year too. Humber Youth Action Group, well, my goodness, it just goes from strength to strength. That started not long after I started. Betsy is not here. Her name has been met several times this afternoon, and again, she's been a star. But also the stars are all the young people who are involved as well. And well done to Anya as well, and others involved in that. I'm just wondering if I missed anybody there, but I think I've covered pretty much anyway everyone on that. And Alan and Sophie, I did see at the launch. And it was great to see them again today and hear their voices and see their contribution to everything. So why do we have these sort of events? I mean, I think on one level, caring together, I always think, is actually, at the end of the day, caring doesn't cost anything. It doesn't. I mean, actually just, being kind, caring about people. Hopefully that's something we can do as individuals and together as well. But actually, through caring, trying to see how we can listen and improve our services does mean something more. It does mean that can we actually reflect and think about the way we do things, and even if we feel we're doing things well, can we do them better? Now, I don't know about some of you, but every now and again I like catching up on Call the Midwife. And I caught up on an episode the other week. And for those who watches, anyone watch Call the Midwife here? Or the Midwife? No. And do you know what? It was I caught them on the other day, and about measles out. They were trying to get parents to get their children vaccinated against measles. But sometimes find with Call the Midwife, you've got this lovely in an artist's house with the nuns and the midwives and the nurses working in Poplar in London. And actually, as anyone who's watched the programme, we've seen the NHS being born. I think we're in the 60s now, but I don't think we've quite got to the 70s. And sometimes where you see the relationship between the nuns and the midwives and the nurses, and then suddenly you see a bit of the NHS. The NHS doesn't always come off that well, I think, in Call the Midwife. Sometimes they're seen as a little bit distant, and look, you've got to fit into our box. And only if you fit into it. I mean, apart from the fact that all the doctors are smoking, that's another thing that's going on in the 60s as well. But anyway, you've got to fit in a box. And so sometimes I feel like you've got this really lovely sort of, the nuns and everything. And then every time it comes into contact with the NHS, we only see a little bit of it. It's always them sort of being a bit strict and a bit organised, and you've got to behave like this and all of that. I hope that in many ways, that's something we're trying to really change in terms of people's perceptions about the NHS, because it's the right thing to do, but also actually it is the best thing to do, because we know, and the evidence demonstrates that actually if you listen to patients and carers, not only can they get better care and treatment as they need and support, but also fundamentally we can do things better as well. And actually it might relieve us from doing things that aren't having any impact, that are taking a lot of time and energy and resources up. And so doing this is because, as I say, it's the right thing to do, but it's also the best thing to do, but also in working in a different way and using other ways to deliver our services and communicate, again, it can actually make sure that our staff in all their guises, and we have a multi-talented staff of doing all sorts of different things, can feel every day in their job they're being able to be better and improve. And that's another important part of this as well. Patient care as a voice is really important, but hearing, if you like, from the shop floor what our staff think, and if they were empowered to do things differently, what they could do, is really part of all our success as well. So I just want to say thank you very much to everybody. All the presentations we've had today that showcase the remarkable strides we're making, and there's always more to do. The people who have given their time, their voices, their insights, their patience, I think, as well, in working with us, because these things don't change overnight. I'm very proud of Humber and how, despite the challenges that there are, and there are challenges every day, there are challenges beyond our doors as well in the wider NHS, that we can still show that we can make a difference. And sometimes it might be just small actions, but in the end of the day, there is a person on the receiving end of that small action for whom we're doing better. So a special thanks to all of you, a special thanks to our volunteers and events teams who help make these events work so well and give their time to so many different projects. I think we have literally had an excellent showcase today, but it is a snapshot of all the work we do. And to Mandy and your team and everyone else, David and others who work every day, sort of trying to make sure we are hearing voices, but not just hearing voices, but taking action. Thank you so much. So have a safe journey home and have a wonderful weekend. Jean, yes, I knew that I would have one heckler in the room. Thank you very much, Jean. I thought I could get away with it.
No, I just wanted to say publicly an acknowledgement of your generous spirit. Good on you, girl.
Thank you, dear. Thank you, Laurie. So anyway, I'm going to leave now. I'm getting embarrassed. But have a wonderful rest of the week. Enjoy Valentine's Day. May the love be with you. Thank you.
Right, thank you all ever so much for your continuous support all day, listening to all the presentations. I hope you've had a very, very informative day. I have. Hope you have too, and have a safe journey home from me and Kath. Thank you.